So let me discuss in detail what was reported in the GCEM. So this case started on February 28, 2020, wherein an 18-year-old female underwent an oropharyngeal swab for SARS-CoV-2 on the evidence that her father, who lived with her, had been hospitalized 2 days earlier because of COVID-19. As you can see in the illustration, her swab turned out to be positive. That's February 28. Okay. In the next few days, she developed mild upper respiratory tract symptoms, which included rhinorrhea, cough, fatigue, and low-grade fever. She was left untreated and recovered completely in 4 days. So as you can see, after just a 4-day course, she recovered completely, and 2 additional swabs several days after turned out to be negative. However, on March 17, so again, as you can see in the illustration, the patient presented with sudden fever at 37.5 degrees centigrade, fatigue, palpitations, and a very typical anterior neck pain radiating to the jaw. And because of the worsening neck pain on March 19, the patient was eventually referred. Okay, so as you can see here, that's 20 days after the initial swab positive test. The patient manifested with neck pains, fatigue, palpitations, typical signs of thyrotoxicosis. There were no very evident signs of upper respiratory tract infection. At this time, laboratory exams included thyroid function testing. Okay, so at this time, as you can see in the arrow, several tests were done. So at laboratory exams, free thyroxine FT4 and FT3 were both mildly elevated. TSH was undetectable. Thyroglobulin was detectable at low level with positive thyroglobulin antibody. I will show to you in detail later the laboratory test. Thyroid TPO antibodies and TSH receptor antibodies were likewise negative or normal. Acute phase reactants, the inflammatory markers like ESR, C-reactive protein, as well as white cell count were normal. A thyroid ultrasound was also done at this time, which showed multiple diffuse hypoechoic areas. So at this particular time, they were entertaining subacute thyroiditis. It is very important to take note also, which was really very nice with regards to the presentation of this patient, is that this patient actually underwent thyroid evaluation even before the occurrence of symptoms. So that's even before the swab positive test. And she was evaluated because of one history of isolated hyperthyroxanemia. And those evaluations done February 21 all revealed normal results. Thyroid function test was normal, antibodies to thyroglobulin were normal, as well as TPO and SHAB and ultrasound results were also unremarkable. Thus, with her current presentation, she was diagnosed to have subacute thyroiditis. And on March 20, so as you can see here, the patient was started on steroids, prednisone at 25 milligrams once a day. Eventually, as you can see in this temporal relationship, neck pain and fever disappeared within 2 days, and the remaining symptoms also abated within 1 week. And on April 1, FT4 concentration had declined to the upper normal range, TSH had risen, and eventually the steroid was tapered. Okay, and on discharge, thyroid function test turned out to be normal, and she was completely asymptomatic. Okay. So these are the tests that were done. So as you can see, at the time that the patient manifested with subacute thyroiditis, you will see that the thyroid ultrasound showed multiple hypoechoic areas, as you can see with the pointer. And if you look at the laboratory results, that showed you the undetectable TSH, okay, the elevated FT3 and FT4, which is consistent with thyrotoxicosis. You also see the elevated thyroglobulin antibodies, and if you compare that to the pre-infection, okay, pre-COVID value, you will see that there was the de novo increase in thyroglobulin antibodies. Likewise, TPO antibodies were remained to be low or normal. So as you can see, as I've said earlier, the acute phase reactants, WBC, ESR, and CRP were elevated at the time of the thyrotoxic phase of the subacute thyroiditis. And eventually, after a few weeks, okay, and after steroid treatment, you will see the resolution with regards to the thyrotoxicosis in the thyroid function test, as well as normalization of the WBC count, as well as the ESR. Okay, so this is what we call a typical phase of subacute thyroiditis. So we are well aware of the effects of viral infection and its relationship with the thyroid gland. So we know that the thyroid gland and viral infections are known to be engaged in a complex interplay via hormones and immunomodulatory signaling molecules. And these connections have been established in both physiological and pathological setting. Viruses with its associated inflammatory immune responses could be regarded as a major variable which might affect lifelong thyroid function. We also acknowledge the fact that some autoimmune disorders may actually be triggered by a viral infection. So that is why we usually say that viral infection can actually contribute to define what you call your thyroid biography. So Hashimoto's thyroiditis, other autoimmune thyroid disorders can be triggered by thyroid infection, just like Graves' disease, and even Guillain-Barré, which is also an autoimmune condition, can be triggered by viral infection. It is now very important, of course, to take note of this condition, especially the physiologic characteristics of the thyroid that is important to COVID-19 infection. We have to remember that thyroid hormones modulate both innate and adaptive immunity through both genomic and non-genomic mechanisms. Physiologically, we know that concentrations of T4 and T3 stimulate the production and release of cytokines. And knowing one of the more problematic courses of COVID-19 infection is characterized by your cytokine storm, so that physiologic concentration of T4 and T3 can potentially increase morbidity and mortality of the cytokine storm, which characterize systemic viral infection. So another important physiologic characteristic of the thyroid that is important to COVID-19 infection is that thyroid hormones are capable to potentiate the antiviral action of interferon gamma. So because of this, we have to bear in mind that thyroid hormones can modulate eventual response to infection. As I've said earlier, there are some pathways of immune responses to viral infection that are observed in thyroid disorders, especially your autoimmune thyroid disorders, your immune checkpoint inhibitor-mediated thyroiditis, whereby your helper cells can actually induce autoimmunity. So that is why we say that viral infections are environmental stimulus precipitating or accelerating autoimmune thyroid disorder development, and as I've illustrated earlier, may be a cause of subacute thyroiditis. So another physiologic characteristic is that we have to bear in mind that respiratory infections could potentially precipitate a thyroid storm. So this particular bullet will be important for those patients suffering from thyrotoxicosis, so that a patient with Graves' disease, for example, can suffer from thyroid storm because of concomitant COVID-19 respiratory infection. And lastly, it is also known that T4 is known to activate human platelets, and we also know in the pathophysiologic mechanisms of COVID-19 infection that there are pathologic variations in coagulation factors. Now, there are increased risk for thrombosis, so that this physiologic effect of T4 can actually also worsen outcomes. So broadly speaking, there are two plausible mechanisms of COVID-19 injury of the hypothalamic pituitary thyroid axis, as you can see in this illustration. your SARS-CoV-2 virus can directly affect, probably has a direct effect, no, a direct viral effect or via immune cells, no, in the hypothalamic pituitary thyroid axis, or may have an indirect effect through abnormal immune inflammatory responses to the virus. So these two potential mechanisms can alter responses of the thyroid directly, a primary thyroid disorder, or may affect the central nervous system through the hypothalamic pituitary thyroid axis. And this is because, as we all know, the endocrine glands can be affected by COVID-19. So in this particular illustration, you will see that the thyroid may be affected, no, normally just by CQ thyroid syndrome, but as you can see in the example earlier, subacute thyroiditis may occur. It has been noted also that there are possible transient hypothalamic pituitary dysfunctions in those patients suffering from COVID-19 infection. There may be alteration in ADH secretion causing dysnatremia as a frequent manifestation of patients suffering from COVID-19 infection. There may be alteration, or higher susceptibility of the testis, for COVID-19, effect on the bones, as well as effect on the pancreas. So we now know that there are new onset diabetes after COVID-19 infection. Now, aside from possible effect causing adrenal insufficiency because of the infection, and we also know now that there are actually worse outcomes in patients who are obese. So that the endocrine system, not just the thyroid, is affected by COVID-19 infection. And why is this so? Just a short review, this is how cellular entry of SARS-CoV-2 virus occur. So that in susceptible cells, as you can see in the illustration, we have binding of the virus to the receptors in the susceptible organs or tissues. So in the middle, you have the illustration of the virus. So you have the very typical RNA virus together with the spike proteins, and these spike proteins will eventually bind to the receptors of the susceptible cell. And SARS-CoV-2 use your ACE2 or your angiotensin converting enzyme 2 combined with your TMPRSS2 or your transmembrane protease serine 2 as the key molecular complex to enter the infected cell. So as you can see here, you have your transmembrane serine protease together with your ACE2 that will help the binding of the COVID-19 virus to the host cell. But aside from those, you also have attachment of ACE2 and your TMPRSS together with simultaneous increase of other multiple proteases, which include your furin. So these three very important co-modulators of viral entry is very important. So it's very important that we note those specific cells that would have large amounts of ACE2 receptors, as well as your transmembrane protein protease serine, as well as your furin proteases for the cellular entry of your SARS-CoV-2 virus. So if you look at several studies, particularly looking at ACE2 expression in human organs, again, it's not just the lungs that has your ACE2 receptors, but as you can see in the illustration, you have a myriad of cells with a large ACE2 expression, which of course include the brain as well as the thyroid gland. But more than that, this is a very nice analysis looking at the overview of SARS-CoV-2 vulnerable tissue targets. So in this particular study, they tried to analyze systematically across 36 tissues, and they tried to rank or list the candidate cells which are potentially vulnerable to SARS-CoV-2 virus. So this study tried to analyze the expression of ACE2, furin, as well as the transmembrane serine proteases. And they looked at 14 candidate target tissues. But aside from the expression of the ACE2, the furin, and the serine proteases, they also looked at the subcellular location of the proteins. So because not only protein levels, but also their subcellular location in a specified type of cell were considered, because the subcellular location determines the routes where viruses might access the protein receptor. So easier access will mean increased vulnerability of the cell. So when they did analyze the vulnerable tissues, they did mRNA profiling and eventually linked the list of potentially vulnerable tissues for SARS-CoV-2 virus. And this is surprising with regards to the tissue distribution of ACE, your transmembrane serine proteases, and your furin proteases, particularly looking at the top panel. So that's ACE expression, your TMPR SS expression, and your furin expression. Now, if you look at this profiling and tissue distribution of ACE2, you will see that thyroid glands actually has more ACE2 expression compared to the lung tissues. So based on tissue distribution through messenger RNA profiling, as well as protein expression scoring, you will see that thyroid gland actually has more ACE2 compared to the lungs. But as I've said, when they rank the vulnerable tissues, they not just look at tissue distribution, but also subcellular localization and RNA profiling. And thus, in this systematic analysis across the 36 tissues, revealed a ranked list of candidate cells potentially vulnerable to SARS-CoV-2. And the top targets are your lung, lung cells, and the macrophages, then followed by the cardiomyocytes and the stromal cells, which included the adrenal gland, followed by the testes and the ovaries, as well as the thyroid gland. So the kidneys, the proximal tubules, the cholangiocytes, and the enterocytes are less likely to be the primary SARS-CoV-2 targets. So this particular study just showed us that the thyroid is really a vulnerable tissue for effects of the SARS-CoV-2 virus. So that this will translate to COVID-19 related thyroid disorders. So these thyroid disorders manifest as either thyrotoxicosis, hypothyroidism, and non-thyroidal illness. Again, this will be discussed in detail by the next lecturers for the next few days of the convention. I'll just go to highlight some of the manifestations of COVID-19 related thyrotoxicosis. So these conditions include subacute thyroiditis, painless thyroiditis, and of course, Graves' disease. So I've discussed earlier subacute thyroiditis, which is said is also called your de Quervain's thyroiditis. It is usually a self-limited thyroid disease caused by a viral or post-viral inflammatory response. Neck pain is the hallmark of the clinical symptoms. That is why another term for subacute thyroiditis is painful subacute thyroiditis. The clinical course of subacute thyroiditis is characterized by these three consecutive phases. The initial phase is thyrotoxicosis, which occurs during the first few months of the disease, followed by hypothyroidism for about 3 months, and then by euthyroidism. So there is usually resolution of the manifestations. We also know that many viruses are known to be associated with the development of subacute thyroiditis, and evidence for infection can be based on epidemiology, on laboratory parameters, on imaging, as well as even direct evidence of viral infection to the affected tissue or the thyroid, okay? So this is a list, aside from the case that I've shown you earlier, this is a list of the reported cases of subacute thyroiditis, okay? To date, now with regards to COVID-19 infection related to thyroid disorder. So just to highlight that in this collection of COVID-19 related subacute thyroiditis, patients in these cases were all females except for one, okay? There were no previous history of thyroid disease, so there were no history of autoimmune thyroid disorder as well as previous thyroid dysfunction. As you can see here, most of the symptoms actually appeared 17 to 40 days after the initial COVID-19 infection. So these are the important characteristics. all actually presented with neck pain, no, except for one patient who was on chronic analgesics because of back pain. And another manifestation is that TPO antibodies, as well as thyroglobulin antibodies were negative at baseline. And also part of the outcomes is that 2 of the cases of subacute thyroiditis eventually did not normalize but eventually developed hypothyroidism. Okay? So another outcome of COVID-19 infection presenting as thyrotoxicosis is painless thyroiditis. So the presentation is basically the same, but there is absence of neck pain and there is TPO antibody positivity. So we sometimes call painless thyroiditis as silent thyroiditis. Now, in this particular study by Lania, this is the ThyroCov study, okay, wherein hospitalized patients for COVID-19 in non-intensive care unit was found to be affected by thyrotoxicosis in the absence of neck pain. As you can see in the panel on the left, so these are patients with elevated serum T4 values at baseline, at infection that eventually decrease, okay, at 10 days. So these are patients with out neck pain and a positive TPO antibody. So they were identified as patients with COVID-19 related painless or silent thyroiditis. So we also take note that overt thyrotoxicosis is defined as low TSH, as you can see at the panel on the left, okay? And this was shown with inverse robust relationship between serum TSH, so that is the panel on the right. As you can see, TSH were low with elevated serum interleukin. So this relationship shows us the inflammatory response of the thyroid because of the levels of interleukin 6. So in the ThyroCov study, they postulated that this thyrotoxicosis is due to, okay, painless thyroiditis. Moreover, it was noted that thyrotoxic patients in hospital mortality was higher, okay? As you can see on the panel on the left, based on the number of hospital mortality was higher in those patients with more suppressed TSH, those who are more thyrotoxic, as well as hospital stay was longer for those patients who had more suppressed TSH and higher FT4. Therefore, they concluded that thyrotoxicosis appears to be clinically relevant in COVID-19 patients because they may negatively impact outcomes. So you may have poorer outcomes if you have thyrotoxicosis together with COVID-19 infection. In another study, okay, looking at the COVID-19 related atypical thyroiditis. So again, these are patients with thyroxinemic thyrotoxicosis. Now, these patients were compared, those were admitted in the high intensive care unit in 2019. So these are patients without COVID-19 infection. They were compared to those eventual patients admitted for COVID-19. So that's the high ICU 20 and the low intensive care unit 20 ICU. As you can see, TSH concentrations for those patients admitted in the high intensive care unit in 2020 had lower TSH as well as higher, okay, CRP concentrations compared to those patients admitted in 2019 as well as in those low ICU admissions. So COVID-19 seems to also affect the severity of thyrotoxicosis in this group of patients. And lastly, COVID-19 can actually be a trigger for new cases or relapses of Graves' disease. There were 2 reported cases of COVID-19 related Graves' disease documented by Matthew, one with the previous history of Graves' disease that was in remission for about 30 years, that was again triggered a relapse, and another patient at another young patient with no history of thyroid disease, which seemed to trigger either new cases or relapses of Graves' disease. So that shows you that COVID-19 can present with thyrotoxicosis. On the other hand, COVID-19 also may present with hypothyroidism through two mechanisms, either affecting the hypothalamic pituitary thyroid axis, causing central hypothyroidism, or secondary hypothyroidism, or directly affecting the thyroid, as we saw earlier, or primary hypothyroidism. We also note, because again, there is co-expression of the olfactory epithelium with ACE2 and your transmembrane proteins, serine proteases in various tissues. So that is probably why the pituitary may also be transiently affected, causing pyroptosis, okay, or programmed cell death, now once they are infected by SARS-CoV-2 virus. So in a study, whereby central hypothyroidism, in this particular study, it was defined by chemically defined as low FT4 with inappropriately normal or low TSH. They noted hormonal changes consistent with central hypothyroidism. When they looked at thyroid function tests of those patients with COVID-19 compared to those with healthy control and non-COVID-19 patients suffering from pneumonia, they noted that the TSH values of those patients with COVID-19 infection were a lot lower, together with a lot lower T3 and T4 values compared to those patients who are healthy and non-COVID. In this particular analysis, central hypothyroidism was diagnosed in 2 to 6% of the patient population who had low FT4 with low or normal TSH. And the reversal of these hormonal changes occurred after recovery of COVID-19, a fact that highlights plausible acute transitory effect of COVID-19 on the HPT axis. So in this study, they noted that the HPT axis may be affected, although transiently. So in another trial or another retrospective study, they also looked at thyroid function tests of those patients with COVID-19, non-COVID-19 pneumonia, as well as healthy subjects. And they also noted the same thyroid function pattern, whereby TSH is low with low normal TSH, as well as low FT3 and FT4, which may be consistent with central hypothyroidism. So primary hypothyroidism developed in those patients with subacute thyroiditis due to chronic autoimmune thyroiditis, and these were recorded among patients with COVID-19 admitted at the high-intensity care unit in this group of patients. As you can see here, patients had persistent elevated TSH, thus developing primary hypothyroidism. So there is some evidence that primary hypothyroidism could occur during or after COVID-19 infection. So this patient should be followed up even after discharge. So lastly is non-thyroidal illness, which is actually the more common manifestations of abnormalities in thyroid function tests among patients with non-thyroidal illness or illness not really affecting the thyroid gland. So this is defined as an adaptive response of the thyroid to acute or chronic illness. So non-thyroidal illness, or what we call sick euthyroid syndrome. Okay. So they are characterized as having mild sick euthyroid syndrome, moderate, severe, and another characteristic pattern is the recovery pattern. When we say mild, these are patients, as you can see in the graph, with normal or elevated TSH, with elevated or normal T4, and reduced T3. So the mild pattern of sick euthyroid syndrome is a low T3 pattern. The moderate SES is characterized by low T3 as well as low T4 with normal TSH, and the more severe pattern is characterized by low T3, low T4, as well as low TSH. Okay, so the initially low T3 is due to the reduction in the peripheral conversion of T3 and T4 because of the increased inflammatory response. The low TSH, on the other hand, in severe sick thyroid syndrome is due to the effect in the hypothalamic function of the TRH, as well as the pituitary function for the secretion of TSH. So in most patients with infection, they may present with what we call non-thyroidal illness or CQ thyroid syndrome. And this is true in a longitudinal study of TSH and free thyroxine in those patients admitted again for COVID-19 infection. So these are those patients admitted at baseline, their initial TSH and their initial T4. And at admission for COVID-19 infection, you see the suppression in TSH as well as the low levels of T4, which eventually normalize after resolution of the infection on follow-up. So this is consistent with what we call CQ thyroid syndrome. And the degree of suppression of TSH, total T3 and total T4 is somewhat related to the degree or the severity of the infection. As you can see, the more critical, the more severe, the more moderate COVID-19 infection, you see a consistently lower levels for both TSH, total T3, and total T4. And when they compared patients with moderate, severe, and critical illness, okay, for those patients without COVID-19 and with COVID-19 infection, you will see that those patients with COVID-19 infection actually had more suppressions in their TSH, total T3, and total T4. So basically, this slide shows us the summary of the effects of COVID-19 infection in the thyroid. So the virus can induce infection and direct effect, as well as indirect effect. The indirect effect causing non-thyroidal illness. It can affect the hypothalamus and the pituitary, causing hypothalamic pituitary dysfunction. It may have direct effect causing subacute thyroiditis or thyroid cell destruction, thus causing thyroid dysfunction. And in the immune-mediated damage of the thyroid gland, we see what we call the subacute thyroiditis. So in conclusion, we as physicians should be alerted about the possibility of this additional clinical manifestation related to SARS-CoV-2 infection, and that is effects of the virus to the thyroid gland. Although there are no available data yet to suggest that patients with pre-existing thyroid conditions are at higher risk for COVID-19 infection or its complications, but we should be aware of the possibility, especially of thyrotoxicosis in this group of patients. Lastly, in patients severely affected by COVID-19, changes in thyroid function and specific thyroid-related damage and sequela may also occur, requiring further investigation. Thus, we should be aware of the consequences of the infection, thyrotoxicosis, hypothyroidism, and CQ thyroid syndrome. I think that's the last slide. Thank you very much.
So thank you, Dr. Matawaran, for that wonderful lecture. I really believe you are the most appropriate speaker, for this first lecture, because it's full of biochemistry and cellular processes. Okay, so we have several questions. So I am really enlightened with your lecture. Thank you, Dr. Bien. Very enlightening lecture and exciting lecture. No, hindi ako inantok talaga. Okay, so we have several questions in the chat box and in the Q&A. So the first question asked is, is there a correlation between the severity of COVID-19 and the severity of the de novo thyroid disorder?
Yes. Okay. So there was one.
Like if the
So the problem, as you all know, it's very difficult to actually interpret thyroid function test in someone who is ill. Okay, so that most of the time, diba ang hirap niyan, Liza? In most of the time, we label them as a non-thyroidal illness. But I think what is important to take note in the studies, in the THYRCOV studies, they, especially those patients manifesting with thyrotoxicosis, they noted that those patients admitted in the high intensive care unit versus the low intensive care unit suffered more with more severe thyrotoxicosis symptomatically as well as biochemically. And there were instances that those patients with thyrotoxicosis, be it painless thyroiditis or true thyrotoxicosis, there were two patients who had reported to develop atrial fibrillation. So that could be because of the thyroid, or it could be something else or part of the disease. Then we say, especially for thyrotoxicosis, I think we have a lecture on that it could actually predict also mortality and morbidity. So, but what do we do with it? No, that's the harder part not to answer, because sometimes we just actually monitor. As you all know, for thyroiditis, usually we just give either NSAIDs or steroids if painful, but for painless, we just treat them symptomatically. Likewise, we give beta blockers, for example, for the palpitations or for the tachycardia. But yes, there is correlation with regards to thyrotoxicosis and severity of the COVID-19 infection and eventual risk for worse outcomes. So I hope I got that point and I was able to answer it.
Okay. Okay. Thank you, Dr. Bien. Okay, so another question. So this is associated with the first question, no? When should we consider possible thyroid dysfunction in COVID patients in the absence of goiter or past history of thyroid disease? So because as you explained earlier, Doc, it's difficult to interpret thyroid thyroid panel, no, in patients who are critically ill, and they might usually just show non-thyroidal illness. So is there a way for us to determine whether the patient has a previous thyroid dysfunction that can exacerbate the COVID-19 infection, or in the absence of goiter or any past history of goiter?
Okay, so I think there are recommendations that came out from the British Thyroid Association and even from the Endocrine Society. The recommendations are clear for those patients who already have thyroid dysfunction. Okay, so I think it's relatively simple. Again, we have lecturers on thyrotoxicosis and hypothyroidism. So basically, if you have COVID-19 infection, I think it is incumbent upon us physicians that if you have a patient with thyrotoxicosis and hypothyroidism, that you have them checked. The harder part are those patients who have no known thyroid disease. The WHO came up with a recommendation. I think, although it was, I have not come across a newer recommendation. The recommendation, if I'm not mistaken, came out either May or June, whereby they don't recommend routine thyroid function testing for those patients without overt thyroid abnormalities. Meaning, historically, okay, the patient has no thyroid disorder, then it is not routine to check their thyroid hormones or their thyroid function test. Okay, that being said, the answer is very, very difficult, so that you just have to for those patients na walang thyroid disorder, right, as baseline, you just have to be aware that disorders may manifest, at least from all of the reported data. I think the more common and easy to recognize thyroid abnormality is still subacute thyroiditis, and the cues are very simple to diagnose. The neck pain and thyrotoxic symptoms post-infection is the usual clinical course that we can easily catch. But the others, I think, more of biochemical than anything else. So the short answer is, for those patients with thyroid disorder, have their thyroid functions checked. But for those without, the recommendations are just to monitor and look for manifestations of disorders.
Okay,
So
thank you, Dr.
it's not
Bien.
a
So,
routine test. Yeah.
okay, so it's not routine to get your thyroid panel if you don't have, if the patient does not have a past history of thyroid dysfunction or does not present with symptoms pointing to thyroid problems.
Yeah.
So, further, you talked the case report earlier about subacute thyroiditis. So we know that part of the management is giving your steroids, no? And in the case report, it's prednisone that was given. So a question here is, can we use dexamethasone for COVID-19 induced thyroiditis? Since for severe COVID-19 cases, we also give dexamethasone.
Yes, no. So what
Okay.
is important is to give the the anti-inflammatory dose. So for subacute thyroiditis, we give either steroids or non-steroidal anti-inflammatory. There are case reports that patients were given ibuprofen and they improved also. So pwede. So dexamethasone, of course, is given. No, for those patients being given dexamethasone, especially for those you may indicate indication for hypoxemia, etc., the dose for dexamethasone is way beyond inflammatory dose. So that would be enough. So in the case report I mentioned, I think the prednisone dose was just 25 milligrams. So that's around zero point 0.5. So the inflammatory dose is around zero point 0.5 to 1 milligram per kilogram of prednisone. So that would be enough.
Okay.
So pwede na
So,
yun. Dexa.
okay. Thank you, Doc. So, will the steroid treatment of COVID-19 in a way modify the course of the thyroid disorders induced by COVID-19 since the dose is much higher?
Probably. So if that is just subacute thyroiditis, we expect resolution of the subacute thyroiditis faster with the higher doses. No? But you'll be surprised, just to complicate things, there are also case report now that the thyroid, the effects on the thyroid may not just be affecting the follicular cells, meaning thyroid hormone production. There are now studies also showing that the parafollicular cells, okay, or the
Mm.
calcitonin producing cells may actually be affected now by SARS-CoV-2 virus, so that there are now reports of um, osteonecrosis of the femoral head, okay, because of that
Mm.
possible effect concomitant with vitamin D deficiency, that there could be more bone effects of SARS-CoV-2 virus. And they say that this could be an interplay of a lot of things, no, aside from the effects in the parafollicular cells, aside from steroid use, no, aside from
Mhm.
vitamin D, so baka ma-affect din yun. So there's still a lot of things to learn about it. So kung steroids, usually even for non-COVID kasi, di ba, we also give steroids for usual subacute thyroiditis of whatever post-viral infection that we give. And we usually give a not so long, not so high steroid dose. So I think a higher dose will invariably translate to better outcomes if we're giving the higher doses of steroids, no, for SARS-CoV-2 for another indication, not just for subacute thyroiditis. So it will help. It will help.
Okay. So, another question is there data on what would be the ideal TSH levels among COVID-confirmed patients, considering that most patients presented with suppressed TSH?
Okay, so that's a hard question to answer because based on the data that I reviewed, there's no recommended TSH values. But I think we have to bear in mind that most of these conditions, admittedly, are non-thyroidal illness or sick thyroid syndrome. Okay. So again, the usual characteristic of the thyroid function test of sick thyroid syndrome initially is a low T3 variant, and then a low T3, low T4 variant, and then a low TSH T3, T4 variant. Okay, so having said that, okay, what you usually do is to really just follow up the patients anyway. Okay, so unless you can really pinpoint that there are specific thyroid causes of the manifestations, you actually don't give anti-thyroid drugs. You actually don't give thyroid hormones. In general, the treatment for non-thyroidal illness, no, at least by hypothesis, is replacement with T3 and not T4. Okay, because again, the problem is the reduction in peripheral conversion of T4 to T3. So that if no, you decide on treating non-thyroidal illness or sick thyroid syndrome, there are very small data on the use of T3 and not T4. So you don't give levothyroxine, but you give T3. But again, its value for COVID-19 infection, we don't know.
Okay, thank you, Doc Bien. So, in relation to that answer, so there's a specific question if there is clinical trial information on the management of thyroid diseases. Is there a are there specific clinical trials studying how we can manage thyroid diseases during COVID?
Uh, uh, I'm not aware of any. Most of the studies are retrospective studies. So let's ask the next few speakers after me in the next few days if they have updates on specific prospective trials. I think there are studies for thyroid cancer. No, I think I've read on it, but not specific for the other disorders. So most of the studies are retrospective studies anyway.
Okay. Thank you, Dr. Bien. Probably the PTA can conduct a survey, no, among the practicing thyroid specialists on their experience on COVID-19 cases. So probably we can answer one more question. So if is there a concern for COVID vaccination in patients with thyroid diseases, particularly those with autoimmune thyroid dysfunction?
Okay.
Or do we have data on that? Or because we know that the data on vaccines are mainly focused on general diseases and not specifically for patients with thyroid disorder.
I will defer my answer to that, not to someone
Okay.
else who would probably know. I'm sorry, but I am not aware of, at least for the vaccines that are available now or will be
Mhm.
available in the future, I'm not aware of any contraindications no, for those patients, both with hyper and hypothyroidism, for not getting the vaccine. But again, I will defer uh, the answer to someone who would probably have more experience or knowledge about vaccinations in those patients with thyroid disorders.
Okay. Thank you, Dr. Bien. So there are still additional questions in the Q&A. I'll probably just ask one last question because the other questions are mainly about managing COVID-19 patients with hypothyroidism and thyrotoxicosis. So I believe the next few speakers will be able to answer those specific questions. So um, probably the last question I will ask is, in a patient with a non-toxic goiter or a non-toxic nodule, will these patients be at increased risk for subacute thyroiditis when they develop COVID-19? So that's the
Um,
last question.
so no. So there is no increased risk. No. The problem with so in general subacute thyroiditis versus painless thyroiditis, the difference is the presence of autoimmunity or the thyroid antibodies. So TPO antibodies are really seen in those patients primarily with painless thyroiditis. Kaya sa acute thyroiditis, as far as I know, there's no particular phenotype that will increase your risk. Okay? So ibig sabihin, so as I've shown you earlier, even for those patients who are TPO negative, they may suffer from subacute thyroiditis. So unlike painless thyroiditis, so one of the risks is TPO or autoimmune positivity. So wala, parang malas mo lang.
Okay, thank you, Dr. Bien. So this first session is really a productive one. Thank you, Dr. Bien, for simplifying the pathophysiology of the effects of COVID-19 on the thyroid gland. And it's really a very good introduction to the exciting virtual convention that we have. Okay, so let me now pass the stage to Dr. Robles. Thank you.
Thank you.
Thank you, Dr. Bien Matawaran, and thank you, Dr. Liza Galia. Indeed, that was the first lecture, and we still have so many questions about this particular topic. And I think there's no doubt that he was the best speaker to talk about and set the stage for the next few lectures that will tackle a lot of the issues that you're asking about. No? So I think that it's a good start. We're off to our next lecture. We have a few minutes. I think that pretty much Dr. Matawaran covered a lot of the important things. I think the key point in his lecture is that there's still a lot of questions that need to be answered, and we're still learning a lot about COVID and its effect on not only in the thyroid gland, but in general, the whole systems of the bodies of the patients that are affected by it. No? So thank you so much, Dr. Bien Matawaran and Dr. Analisa Galia Gaboy. So we'll now move on to the introduction of our next speaker. So our next speaker will be introduced by a surgeon based in Manila, Dr. Ida Marie Tabangay Lim. Dr. Ida, you may start to introduce our next speaker.
Yes. Good afternoon, and thank you, Dr. Jeremy Robles. On to our next topic. One of the treatment modalities affected by the COVID pandemic is surgery. During the early part of this pandemic, elective surgeries have been deferred or postponed to give priority to emergency cases and also to protect and minimize the risk of the non-COVID patients. Our next speaker is the best person to tackle this topic. He is a graduate of medicine from FEU and finished general surgery and head and neck oncology from the University of the Philippines, PGH, currently based in Naga, and he is the president of the Philippine Society of General Surgeons, also president of the Camarines Sur Medical Society, and medical director of the Mother Seton Hospital in Camarines Sur. So the topic assigned to him is surgical priorities during and beyond the pandemic. Let's hear it from our speaker, Dr. Roberto Sarmiento from Naga, Bicol. We will be showing a pre-recorded lecture by Dr. Roberto Sarmiento.
Good afternoon. Thank you to the Philippine Thyroid Association for the invite, and thank you, Dr. Ida Lim, for the generous introduction. Today, I'm tasked to discuss the contingencies and the strategic management for thyroid disease management in the time of pandemic, in particular, the surgical priorities during and beyond the pandemic. The talk has the following objectives. First, to discuss the contingencies and strategies for thyroid surgery in the time of pandemic, and to discuss the surgical priorities during and beyond the pandemic. It was the best of times. It was the worst of times. It was the age of wisdom. It was the age of foolishness. It was the epoch of belief. It was the epoch of incredulity. Straight from Charles Dickens' novel, A Tale of Two Cities. This is what really happened during the time of COVID, when, aside from our patients who suffered morbidity and mortalities from the pandemic, even our health care workers, the doctors and the nurses, succumbed to the infection. But at the same time, this is the perfect time to shine for us health workers to meet the challenge of this dreaded pandemic. As soon as the announcement of the lockdown due to COVID-19, the Philippine College of Surgeons immediately came up with recommendations for the management of elective surgeries. In particular, to minimize all electives and urgent procedures, including cancellation of already scheduled surgeries and other procedures such as endoscopy or other interventional procedures. The the Philippine College of Surgeons Cancer Commission came up with guidelines. And during this pandemic, surgeons were forced to consider triage and allocate cancer surgeries. The Philippine Society of General Surgeons adopted the cancer care guidelines from the PCS Cancer Commission, which was actually adopted from the Cancer Surgeries in Time of COVID published by the Surgical Oncology Society of the Philippines. So going to the specific organs for endocrine and head and neck cancer surgery guidelines, for endocrine and head and neck cancer surgery, uh, the recommendation was most of the operations for uncomplicated endocrine operations can be delayed, and diseases and presentations that might qualify for more urgent surgery are the following. For thyroid cancer that is impending threat to life, those that are threatening with local invasion, that is invasion of the trachea or encroachment on the recurrent laryngeal nerves, tumors with aggressive biology, which are rapidly growing or with recurrence, tumors with rapidly progressive local regional disease, including the lymph nodes, or severely symptomatic Graves' disease that has failed medical therapy. So this is an example. I think this is a case of borrowed case from Ida of a patient with a neglected thyroid tumor, which has grown extensively, which caused ulceration and bleeding and infection um, of the thyroid cancer, which necessitates um, thyroidectomy as an urgent operation, even in the time of COVID. Of course, the surgeons are well protected using level 3 to level 4 PPE. This is another example of a patient who was referred to me during the height of COVID, presenting with a huge anterior neck mass, probably of thyroid origin, which already is encroaching on the trachea, causing respiratory difficulty of the patients. Patient necessitated also thyroidectomy. Okay. Other than that, goiter that are highly symptomatic or at risk for impending airway obstruction, or patients with open biopsy with diagnostic intent or suspected anaplastic thyroid cancer or lymphoma. So this is a patient, also a referral, which necessitate a open biopsy of the lateral neck mass, and eventually the patient needed a tracheostomy. Again, we did the operation to because of the immediate need for a diagnostic uh, procedure to do a biopsy and then to insert a airway to do a tracheostomy. Most of the operations for thyroid gland, as mentioned earlier, for thyroid or endocrine problems, can be delayed. So what is the reason behind it? So what is the majority of cancer operations can be delayed? It is because the natural history studies have demonstrated their slow growing nature of these thyroid tumors with tumor stability and low potential for recurrence. 95% of these thyroid cancers are well differentiated. The well differentiated type of cancers can either be follicular or papillary. The medullary and aplastic thyroid cancer account for about 2 to 1% of cancers respectively. Well differentiated tumors are highly treatable and curable. The 10-year relative survival for papillary and follicular cancers very excellent, okay, 99 to 95% respectively. 10-year relative survival rate for medullary thyroid cancer is 82%. Although rare, anaplastic tumors have a poor prognosis with a 10-year relative survival of 7% and account for 20% of thyroid cancer deaths. So, because of the indolent nature of the well-differentiated thyroid tumors, most of them could be managed conservatively. So, the concept of active surveillance of thyroid cancer came into place. Active surveillance of thyroid carcinoma involves closely monitoring thyroid cancer over time instead of treating it with immediate surgery. Okay? Ultrasound is the most common imaging test used to evaluate and monitor the structure of the thyroid gland. Okay? So this is very timely in the time of COVID because of the lack of logistics and fear of the patients and the healthcare workers for possible exposure to a possible COVID patient. You can just closely monitor the progress of the patients over time, okay, and see through serial ultrasound imaging if this patient warrants a immediate surgery. So, active surveillance for patients with very low risk thyroid cancer, according to Loya Hanson et al. From the uh, Memorial Sloan Kettering Cancer Center, okay, according to them, there's a increasing incidence of papillary cancer observed. They have the least behavior and the most common thyroid malignancy, with the mortality attributable to this cancer remain very low. The low-risk papillary thyroid cancer are small intrathyroidal lesions without extrathyroidal extensions or clinically apparent lymph node or distant metastasis. They do not exhibit invasion into the recurrent laryngeal nerve or the esophagus or the airway, and most of them remain indolent over time. According to the American Thyroid Association guidelines, uh, there exists a framework for risk stratifications of patients being considered for observation uh, with papillary thyroid cancers. Patients ideal for active surveillance are older patients with single tumor within the parenchyma with well-defined margins, and patients inappropriate for active surveillance. These are patients with tumors within, within critical locations uh, next to the recurrent laryngeal nerve with invasion of the trachea and with invasion of the esophagus. Those tumors with aggressive cytologic features with evidence of extrathyroidal involvement, okay, and evidence of disease growth or progression. The Memorial Sloan Kettering Cancer Center experience um, on active surveillance involves baseline high-quality ultrasound for measurements of axial dimensions and calculation of tumor volume. Serial ultrasound is then done every 6 months for 2 to 3 years and then annually. Surgery is recommended when the cancer exhibits an increase in size as defined by the 3 millimeter increase in axial dimension or equivalent to more than 50% increase in tumor volume. So active surveillance of thyroid cancer, as proven in the paper, is an accepted and rational approach to the management of well-differentiated thyroid cancer during the pandemic without affecting the outcomes in terms of morbidity and mortality of your patients. So what are the contingency measures adopted by the surgeons during the pandemic? Um, the contingency measures during the COVID-19 involve protection of our surgical team through the rational use of PPE with strict donning and doffing protocols, the upgrading of our operating rooms equipped with negative pressure environment, and highly efficient purification filters. Of course, pre-op testing of our RT-PCR swab of our patients and their bantays, team duty rotation of the surgical team so as not to simultaneously expose our uh, residents and consultants to a possible COVID patient, and prioritization of operations, whether emergent, urgent, non-urgent, and elective operations. Likewise, we have to shut down the OPD temporarily and made use of the telemedicine for consultation and follow-up of our patients. So the Philippine Society of General Surgeons and the Philippine College of Surgeons um, donated the much needed personal protective equipments to the chapters in Manila and outside provinces to be used during extensive surgical procedures, mostly emergencies. The donation of HEPA filters in our operating room, as well as installation of negative pressure environment in our operating rooms. What are the effects of COVID-19 on surgical training? Because of the pandemic, what happened was that there were delayed results of the medical board examinations for 2020 because of the last 2 days of the exam was have to be postponed because of the fear of COVID. There were no first year or new applicants in the more than 100 general surgery training programs all over the Philippines. There are also decreased number of graduates because decreased number of cases for graduating residents affecting the eligibility of our residents. Okay. The rotations likewise of the residents in both in the general surgery and subspecialty rotations were affected, affecting the accreditation requirements of our residents. So what did our board decided? So we have to check with the Committee on Accreditation and Eligibility, work with the chairman and training officers of the more than 100 training programs all over the Philippines, and discuss the accreditation and eligibility problems of common to all training programs in the Philippines. So after getting the feel and uh, of the various training programs in Metro Manila and in the provinces, the board came up with these actions. First, for eligibility, we decided to be easy on the residents. We allowed graduating residents to operate outside their mother institution with guidance of a Philippine Society of General Surgeons fellow. And we usually, before, we usually allot about one-third of the total private cases to be considered as resident material. Right now, we increased the use of the private cases to 50% of the resident material. For accreditation purposes, it was a status quo of the present status accreditation of all the hospitals scheduled for accreditation, and they just have the committee on accreditation just reviewed their annual reports. Also, the PSGS board encouraged virtual conferences over to face-to-face conferences. Okay, this was the last. This was the accreditation visit face-to-face was not allowed anymore. I remember being part of the accreditation team during the visit, summer, I think 2016 at St. Luke's, Quezon City. Okay, we did a visit then, and right next to me was the late chairman of the Department of Surgery of St. Luke's Medical Center in Quezon City, who unfortunately succumbed to the virus. Okay, so all of this accreditation committee um, visits for 2020 were all canceled in favor of a virtual visit to be done this year 2021. Okay, so as mentioned, virtual conferences were implemented in favor of face-to-face meetings, and even our national examination of residents, or the CERES, comprehensive evaluation system of the residents, were simultaneously done online last December 13 all over the Philippines. Okay, amidst setting of social distancing and under the strict requirements of the IATF. Oh, so as soon as the smoke clears, and when there's already decreasing incidence of the COVID infection, the surgeons, the Philippine College of Surgeons, following the cue from the American College of Surgeons, came up with post-COVID readiness checklist for resumption of surgery. Okay, so this is the also the PCS came up with guidelines to resume elective surgery. Okay, particularly resumption of elective procedures will be determined by the hospital and authorized by the government health authorities. It should be compliant with community quarantine and other policies of the national or local government. Uh, Resumption of elective surgery can only be considered only if there is a continuous decline in the rate of COVID-19 cases, and if the hospitals are able to provide adequate number of PPEs, anesthetics, medications, anesthesia machines, monitors, and ventilators, and there is enough support, PACU, ICU, and non-ICU beds to accommodate post-op cases for elective surgery, which previously has been eaten up by the COVID-19 patients. So we follow the guidelines for preparation for post-COVID. Okay, so protocols involve patient prioritization. So we prioritize urgent cases over elective operations. We prioritize scheduling malignant over benign conditions. We prioritize also scheduling operations which are curative over palliative. And we also prioritize non-deferrable operation over deferrable operations. For heart facility factor policies, prioritization involves low resource procedures needing over high resource um, requiring blood. Okay, non-ICU requiring over ICU requiring shorter length stay over length stay, and outpatient or inpatient um, over inpatient operations. Um, More important is the infection control risk for healthcare worker protection. We prioritize non-aerosoling over aerolizing procedures, which explain that in the early phase of the pandemic, most of the minimal invasive surgery were not performed. We did short uh, cases over long procedures, and we did non-invasive over more of the non-invasive operations over invasive intervention, and we preferred regional over general anesthesia. So I think this is the summary of the discussion. Outlook surveillance for thyroid cancers and immediate surgery may be deferred to better times. Okay, this is true for most cases of thyroid cancers, which are well differentiated without affecting the survival outcomes of the patient and the morbidities and mortalities. Contingency measures were implemented versus COVID-19, and the surgeons made preparations for the resumption of surgery back to normalcy. So most of the time, most of the thyroid cancers um, were deferred to a later date, affording more time for the surgeons, for the plantitos to do their gardening, etc. This is the picture of my garden during the COVID, which afforded me more time to devote to as a plantito. So that is my last slide. Thank you very much for your kind attention.
Thank you, Dr. Sarmiento, for the very informative lecture. We have a lot of questions in the chat box, and most of this can be addressed in the succeeding lectures. But for now, we will be focusing on the surgical topics. Okay. I'll just minimize my video na for bandwidth. One question, Dr. Sarmiento, that they want to be clarified is with regards to the definition of delay. No, what do we mean by delay in surgery? Is there such a certain time frame, and is there what we call as significant delay, like beyond this time we should be doing the surgery, we cannot postpone it any longer?
Yeah, Ida, the definition of the delay in surgery is actually ano, uh, equivocal. The decision for the timing of the operation should be based on objective findings. So this calls for a careful monitoring of your patients. Uh, in this case, you can, aside from doing your regular PA palpation, uh, you do your ultrasound, so you can have an objective finding whether there is disease progression. So, uh, as mentioned in the lecture, these are well differentiated. Majority of the thyroid cancers are well differentiated, and they have a very indolent behavior, uh, as described in the textbooks. Most of these patients die with the disease rather than of the disease. So uh, you just have to reassure your patients that, especially in this time of COVID, it's very, uh, it's you can just have to monitor the progression of the disease. If it's not progressive, you can call for a reasonable delay for better times, because studies have shown that if you insist on operating these patients usually have a very terrible post-operative course after surgery, just in case you miss on these patients having COVID before surgery. I hope that answers your question, Ida.
Yeah, so there's no definite time
No
we say
definite time. Yeah.
this is delayed. No, we have to evaluate the patient if there's any urgent symptoms requiring urgent surgery, like for example, airway obstruction, bleeding. Then even though we have the COVID pandemic, we have to do the surgery. Another question is, will the pandemic affect the decision to do subtotal thyroidectomy versus total thyroidectomy?
Yeah, I saw that question in the chat box. Uh, I do not I it doesn't allow, it doesn't affect your decision. Actually, what we still follow the guidelines, no. If there is um, involvement of both lobes, by all means you have to go. You have to do a total thyroidectomy. But if it's confined only to a single lobe, and this patient is a young patient, there's always a option to do a just a lobectomy or a subtotal thyroidectomy.
So we will still follow the existing guidelines. So with regards to
Yeah,
the extent of surgery and the risk of the cancer, whether it's low risk or high risk,
yeah.
no? You
Mm.
need to do the total thyroidectomy or subtotal. Now, with regards to the consultation with your patients, would you prefer teleconsult, or are you doing full face-to-face consultation already?
Okay. During the first 3 months of the COVID, I did not have any face-to-face. I elected to, since I'm already in the senior level. um, most of these patients actually are follow-ups, and they're friends in my Facebook, and we'll just do messenger consultations to messenger. And I also do my electronic prescriptions uh, through the email or Facebook Messenger. And as soon as the number of cases went down here in our area, we started slowly opening the um, our clinics, but only after we have installed the HEPA filters, unidirectional flow, and screening of all patients and their relatives or bantais before they go into our clinics. But during the start of the COVID, no consultation, and we just strictly followed teleconsultation. Right now, we're doing face-to-face already.
Yeah.
Oh, we're doing face-to-face consultation already, of course, with PPEs.
We have a question in the Q&A box, and this is about thyroid surgical missions in areas with low or non-COVID areas in the provinces. What's happening right now? And if I may add to that, no, the vaccine is already being planned, no, to be given. Do you think will the availability or the vaccination program have an effect on the surgery for thyroid cases?
The first question was about surgical
Thyroid
missions. Surgical
low,
missions.
low risk and non-COVID areas.
Yeah.
Is it prudent to continue, or what's happening right now in
Uh,
the other areas?
Actually, in high-risk areas, it's also high risk to do the surgical operations because thyroidectomy is an invasive procedure, aerosolized procedure, and there are studies that indicates that they usually have a stormy course if ever they're COVID patients, uh, and you do thyroidectomy on them. So it would be unwise to do surgical missions in these areas where there's still high incidence of thyroid cancer. But I do agree with you that in some areas where it is actually not present, uh, you may have to go. We have to do. We can offer a mission, but it has to be it has to be uh, really have to be careful to have this cleared. And the problem is with surgical missions is that most of them are not done hospital based. I would be worried if they should be done if ever they should be done hospital based, that can be closely monitored for complications.
So a question regarding the maybe the procedure or the OR time, no?
Yeah.
May not be the OR time itself, but the question is, did it affect the operating time? Did the COVID pandemic affect the OR time?
Yeah. Because with it's very difficult to do the surgeries in complete PPE. You
Yes,
have double gloves. You have
face.
your face shield. You have your goggles. Sometimes very difficult to breathe. So, uh, and same is true with anesthesia. They follow very careful algorithm before the before inducting the patient for anesthesia. So it entails additional time. I remember developing carpal tunnel symptoms during surgeries during the COVID times because of the double gloving, and etc. Uh,
So another question, are there specific gross anatomic changes in the gland that the surgeon need to be aware of? Like, will surgery be more difficult? Like, among patients who had COVID, meron bang studies or actual experience that the COVID infection affected the anatomy of the thyroid?
Actually, I haven't encountered a post-COVID lately, post-COVID pasyente. We did a lot of cancer surgeries before the start of the COVID. Uh, I haven't, so I'm sorry, I cannot answer your question. I haven't encountered this type of patients because we entirely deferred doing thyroidectomies at the height of the COVID.
Maybe we have very little data on that
Yeah,
yet.
yeah,
Have not observed those changes.
yeah.
And a question from, ano, are we supposed, Dr. D from the Visayas? COVID or non-COVID, we know that majority of the papillary cancer cannot afford surgery without incurring death. So will it be proper for patients to be subjected to active surveillance protocol as a standard of care?
Yeah. Actually, it's if you review that paper I presented, it is an alternative. No, it's a novelty, uh, especially for those patients who wish not to be operated or have a fear of operation. But the most important thing is that you monitor these patients for disease progression. Okay. Uh, and certain characteristics that would warrant a surgery.
Thank you, Dr. Sarmiento. I think your lecture has more or less addressed the question of what are the contingencies and strategies that we have in place, plus the questions given to us. So we will just monitor questions, no, that can be answered in the other sessions. So with that, thank you very much, Dr. Sarmiento, and we go back to you, Dr. Robles.
Thank you,
Thank you.
Dr. Sarmiento, and thank you, Dr. Ida Tabangay Lim, for discussing the surgical aspect of thyroid disease during a COVID pandemic. So we've covered the medical aspect as well as the surgical aspect. I think it's just fitting that we end our last session, and we have our last session that will cover nuclear medicine and how really COVID has affected this particular practice. So at this point, I want to thank all our participants, not only here in the Philippines, in Asia as well as the Middle East. We have some delegates attending this conference through MedSynapse. I do know that there are some questions being forwarded to us. Some of these questions can be directly answered with succeeding lectures that we have for the next few days. Remember, this is the first day of the Philippine Thyroid Association Congress or Conference. The second day will be on Wednesday. And then lastly, we have the final day on Friday. It's the same time, 4 p.m. to 6 p.m. Philippine time. So again, we move on to our last session for today. Our next session will be lectured by no other than Dr. Thomas Neil Pascual. He will be moderated by our nuclear specialist from Cebu, Dr. Charles Tan. Charles, you can take over.
Hi. Thank you, Jer. Good afternoon, everyone. Diagnostic and therapeutic nuclear medicine procedure remain as an essential tool in the management of thyroid patients. This afternoon, our lecturer will talk about the impact of COVID-19 in the practice of nuclear medicine. He is a graduate of the University of Santo Tomas and had his nuclear medicine residency training in UST Hospital. He had his fellowship in pediatric nuclear medicine and PET-CT at the Children's Hospital in Australia, and his master's degree in health professions education at UST Hospital and health economics at the University of Aberdeen in the United Kingdom. He worked as a professional staff member of the International Atomic Energy Agency, or IAEA, from 2012 to 2019. Apart from his scientific papers, he was awarded as a Distinguished Filipino Nuclear Medicine for International Leadership given by the Philippine Society of Nuclear Medicine last February 2016, and the Balik Scientist Award from the Department of Science and Technology last March 2019. He is currently an active consultant in nuclear medicine at UST Hospital and is the executive director of the Asian School of Nuclear Medicine. It is with great honor to present to you this afternoon's speaker, a good friend, an esteemed colleague, and a radioactive physician, Dr. Thomas Neil Pascual.
Good afternoon, everyone. Thank you, Charles, for the kind introduction. I would like to thank the organizers for inviting me in this session. So I'll proceed with my presentation. Okay, so I was given the task to give an impact of COVID-19 in the practice of medicine. And then, as we all know, the practice of medicine would cover different areas from clinical services, education and training, and as well as research. And since the COVID pandemic happened, a lot of these actually changed. We have a new normal. We changed everything on how we work, not only locally, but definitely around the world. So what we did was we tried to examine what are the different effects of COVID-19 in the practice of medicine, as it covers the entire spectrum of seeing the patients, releasing of the results, to the area of education and training of the trainees and research activities. So COVID-19 indeed did a huge impact in the practice of nuclear medicine. And what is commonly seen was there was a huge reduction in the number of services or procedures done. In a study done by Paes et al., including myself, published at the Journal of Nuclear Medicine last year, when we did a survey, including participants from the Philippines, we were able to document that there were at least, above all, at least 50% reduction in the procedures being done. And for thyroid imaging, it went as low as 67% reduction. So the impact of this would be much more realized in the years to come, because we know that there are the health outcomes that will actually happen after a few years because we missed diagnosing those important cases. So we are seeing a much more bigger burden perhaps in the medium to long term as we try to catch up with the backlog of important imaging procedures done mainly on non-communicable diseases. When we did another survey on the impact of COVID-19 on the diagnosis of heart disease, indeed it showed, again, similarly 64% reduction in cardiology diagnostic procedures compared to the previous year. And as we all know, that cardiovascular diseases still remains one of the highest mortality worldwide as far as NCD is concerned. So imagine at least there's a 64% reduction, we would see down the line that more and more patients will resurface with probably higher cases of NCDs or cardiovascular diseases. So having said that, the International Atomic Energy Agency saw that the 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 practice of nuclear medicine has changed, but there were not enough guidelines on how to go on with the procedure of doing nuclear medicine around the world. So they published a technical document on guidance for nuclear medicine departments during the time of COVID-19 pandemic. So this publication, which is free to download, actually highlights what are the different things that need to be done in the workflow processes of a nuclear medicine department. As we know, aside from the reduction of number of patients that we see because of the COVID restrictions, there are additional protocols that need to be put in place, specifically infection control procedures, so that we can ensure that the patients are protected when they go to the nuclear medicine departments. And it's not totally easy to do. In this figure taken from the publication, they emphasize the importance of triage. And I think all nuclear medicine departments, at least in the Philippines, they have already implemented this triage procedures wherein patients are seen and then evaluated before being referred to the nuclear medicine department. And the important thing about also with this document is it is very crucial that you have to protect your workforce and ensure the healthcare of the workers itself. So we have to see that the patients as well as the workers are protected during the COVID pandemic times, and they have put a number of steps to be done, or at least highlight what are the important things to be done before the arrival of the patients for the test. It means that they have to screen patients for any history of COVID symptoms over the phone. So all throughout the document, they emphasize, of course, as much as possible, minimal contact. So they have to do all phone consultations and also telemedicine. But when the patient comes there already scheduled, you have to follow some certain protocols. For example, on arrival of the test, the healthcare professionals should all have proper PPEs. So supply is crucial. The supply of PPEs is crucial to ensure the safety of the patient and also of the staff. And during the test, we try to minimize contact of the patient and the staff. And then they try. It is important that also during the test that there is. They try to do the test as fast as possible, or try to choose shorter protocols if you can. And after the test, the results are relayed to the referring physicians by phone, and also following certain protocols for COVID prevention. So what are the general principles that they have actually highlighted on this document? First would be distancing. Of course, distancing should include both patient waiting room as well as the work areas. But mostly, scheduling is the best. If you schedule the patient, all of them, in a way that they try to avoid or promote distancing, that's the best. So again, social distancing of at least 1 meter or 3 feet is best, or depending on your best practices. Hand hygiene is important. Staff needs to constantly wash their hands. And here also, rescheduling of non-urgent procedures. So practitioners should work closely with the referring physician to ensure that there are on a risk-benefit basis, that they have to reschedule the patients based on the condition of them, if it's critical or not, or it's a priority or not. The PPE should always be available as much as possible, and also promoting the use of telehealth. So if you look on this table, priority 1 would actually show that the examination should be prioritized in discussion with the referring physician according to the impact of the results of the patient's history. So they have made the following a priority 1 or priority 2. And feel free to look in this table, but for the purpose of iodine 131 therapy, it's in priority 1. And also for thyroid scanning, it's also in priority 1. But certain follow-up procedures are sometimes considered to be delayed. Okay. For oncology, PET-CT for diagnosis, evaluation of therapy, and relapse is a priority, as well as imaging for prostate cancer and also therapy. Again, depending on the risk-benefit analysis being on the patient's condition. For cardiology, myocardial perfusion scanning needs to be done, but only to discard in order to discard significant coronary diseases or to be able to identify. Okay, and then for therapy, yttrium-90, lutetium-177 dotatate, and iodine-131 would still be on the priority after discussion with the referring physicians. Okay, very important here is each patient needs to be assessed on an individual basis as far as therapy is concerned. And it is important that you follow, still again, local guidelines. For radioiodine therapy, appointments for benign hyperthyroidism may be delayed since they are non-urgent and would pose radiation risk and prior to the admission. However, it should be considered that if some patients are unable to tolerate anti-thyroid medications, they should be put on the priority list for to be scheduled for radioiodine therapy. Okay, so same thing would go on with patients for neuroendocrine tumors or prostate cancer. However, some patients could be considered high risk due to possible bone marrow depletion post-procedure. So you have to check that it needs to be discussed if indeed lutetium dotatate, PSMA imaging and therapy needs to be done and also needs to be evaluated based on the risk of the patient. An important thing that actually affected practice with the nuclear medicine and also worldwide would be the incidental pulmonary findings seen on SPECT-CT or PET-CT. And there are increasing number of reports of CT findings of COVID-19 associated pneumonia with hybrid imaging done in nuclear medicine department. So it is important that if you see any suspicious findings on the CT component of the SPECT-CT, it is essential that the nuclear medicine physician would analyze each in the lung windows to see if there is something that needs to be further referred with a radiologist or a lung specialist. Sorry. Now, once the patient is scanned and goes home, it is important that in the cases of PET-CT or SPECT-CT scans, they need to be studied carefully. And then images should be reviewed before the patient is released. And avoid in-person image reviews with the referring services. So this is the part wherein the telemedicine component would actually be very useful and highly advised, as well as telephone discussion, so as to avoid physical contact with the referring physicians or with the patients. The document also wanted to promote the use of telehealth, and the following conditions are actually apt for applying this kind of approach: teleconsulting prior to scheduling, teleconsulting before attending the appointment, remote reporting, national and local rules needs to be followed. Teleconsultation after radionuclide therapies is actually also encouraged, and as well as remote communication channels with the referring physicians. Since in order to have a control with the COVID-19, there are certain tasks that needs to be done by the different personnel within the nuclear medicine department. So the nuclear medicine technologist or radiographer needs to do the following things before, during, and after procedures. So it will be good to look into that table alone. Now, moving forward, Huang et al. Actually published this paper entitled Nuclear Medicine Services After COVID-19, Gearing Back to the Normality. So we have actually dealt with, at least in part, how to deal with COVID-19 procedures during the pandemic. And now they have also published a paper on how to move forward since the COVID-19. And different areas need to be addressed, such as the human resources, the patient flow, the equipment, the radiopharmaceutical supply and the license, emergency supplies, and teaching and training and research. So with this, they have actually recommended that the nuclear medicine department would go on different phases of recovery. Some countries are still in the red phase, wherein they're still in lockdown. Eventually, they would come into what they propose as the amber phase or partial limited restriction, and eventually the green phase or the new normal, wherein they try to increase the capacity of the nuclear medicine services to 90%. So this would likely go on eventually to the green phase once uh, maybe they said that the the vaccine is available already and much more widespread. And the goal of the green phase is to increase the capacity of the nuclear medicine services to 90% and to optimize the workforce. In some parts of the world, there were some layoffs with the different nuclear medicine personnel. So they tried to recover during the new normal phase to try to bring them back while following still strict protocols as far as imaging within the nuclear medicine services are concerned. Again, the important thing again that they would emphasize here is still to ensure that there is sufficient PPEs available for both the patient and the patient and the staff. And also during this time, research services are actually can go back. Just a short note on the management of thyroid nodules and cancer. Most patients with thyroid nodules and thyroid cancer referred for diagnostic workup and treatment are not considered at high risk of infection from COVID compared to the general population. But on the other hand, healthcare resources should be spared to the maximum extent possible during a pandemic. So in these cases, it is important to try to do an individual risk-benefit analysis. Most of the centers would try to defer workup for the thyroid nodules and also thyroid surgeries for either benign or malignant cases. But there should be appropriate patient counseling, which is actually mandatory. And during this time, red flags should be identified to make sure that the patient cases actually move up to a priority level. So overall, COVID-19 in the practice of nuclear medicine indeed affected the workforce and the supply of radiopharmaceuticals, which is one thing. But also important to consider would its effect on the education and training. Before we have a robust educational system wherein there's face-to-face contact. But since the lockdown, during the COVID-19, there were times wherein they have to do emergency remote teaching, which is actually not actually online teaching. Emergency remote teaching is when you do some supplemental teaching over the internet in order to supplement what needs to be done based on the minimum caseload requirements of the learner. So at this point, more and more, as far as the training program is concerned, we are shifting towards more like a blended learning approach wherein face-to-face is actually coupled with online learning materials. And then in cases wherein the students or the residents or the fellows are not able to reach the caseload or the minimum caseload as prescribed by local policy or international policy, it is important to do, let's say, to go on what you have. Trying to build like a community of learners. For example, if Hospital A is very high on cases with PET-CT, then they should look into the cases of those hospitals and share resources online in order to make the caseload minimum requirements. As far as the board exams, since, for example, locally in the nuclear medicine training, there are not too many trainees compared with the other, at least in other countries. So board examination should be done again following strict IATF guidelines. I think what happened here in the Philippines is like they did an in-house board examination because of the number of exam takers are, let's say, less than 5. So, but in cases wherein there are more than 10 people, they would opt for a much more deferred board examination. And in some countries, they would apply the no detrimental policy, wherein the students are actually made to graduate from their training based on the overall average the training years, the past training years. So they were not given, for example, the promotion was given based on the average of the previous years and not doing an actual exam itself. Now, research is actually going back into schedule, but more and more people are actually trying to do research more in collaboration with different hospitals to be able to do research and then combine cases because of limited attendance or also because of limited cases to be able to put into the research. So overall, COVID-19 indeed made a huge impact in the practice of nuclear medicine. We have to do with priority list. We have to look at the cases that needs to be examined and then put them into a priority listing while actually incorporating protocol changes made by the institution. Education and training is definitely affected, and then it still remains a question on how long would this blended learning or face-to-face would actually go back to a full-time face-to-face teaching. But for the moment, it is more of a combination of online and then face-to-face or blended learning. So with that, I would like to thank you very much for this invitation, and that's it. Thank you.
Thank you. Thank you, Tommy, for your very informative lecture. We have a good number of questions lined up for you. First is a question that was earlier posted in the chat box. Is it safe to delay radioactive iodine treatment? Maybe we can categorize this one to patients who have non-malignant thyroid cases and those who have malignant thyroid cases.
Okay. As in the previous slides and also in the previous speakers, I think there needs to be a risk-benefit analysis on radioactive, if radioactive therapy needs to be delayed. If the patient is actually could not sustain anti-thyroid medication, then they need to be put on radioactive iodine therapy. So the priority still is you need to see a much more individualized approach for that.
Okay, another question, Tom, is will the present environment affect decision-making in terms of determining the dose or the dosing for RAI for non-cancer patients?
Okay. The protocols actually would still be the same. Okay. The important thing is with the current situation, it's more of we're trying to avoid the exposure of the patient to the possible COVID when they go to the hospital. So that's the important thing that we have to consider. So from the other research and also from other hospitals, there is no change in trying to lowering the dose on whatever radioactive therapy that you would want to do. So no change.
Okay, so you usually do a consult telemedicine prior to the day of admission, and then before on the day of admission, do you still go to the patient's room to administer the dose, or is it that techs who do it?
Again, case-to-case basis. As long as there's adequate scheduling to make sure that there is not enough staff around, then you can actually go on proceed with your radioactive iodine therapy as long as it's really indicated for the patient. In your case, Charles, how do you do it? Do you go there, or you actually would try to request the staff to be to do that in your behalf? So normally naman kasi I think it's as long as you have the PPEs and you have the supply, which is important, then we can go on proceed with the therapy. So what is actually not endorsed is you actually ordered therapy and then the supply is not there. So you put the patient at risk of going to the hospital or something like that, and then there is no supply. And it happens. So the cardinal rule is there is adequate supply of the radiopharmaceutical. The staff is actually well protected. The PPE supply is sufficient, and the patient is actually adequately advised about the procedure. And as far as, let's say, after the patient is discharged, then the rest of the communication would be more of a telemedicine. But during the therapy itself, it's based on the discretion of actually the hospital, the local policy, because sometimes some hospital really deferred it. But now, as we go on to a much more new normal, then services are actually resumed based on sound scheduling protocols by the hospital.
Okay, Tom. In Cebu, most of the centers are adopting to the new normal that we are giving the radioactive iodine. The challenge is the logistics of the radioactive material to be flying in internationally, coming into Cebu. So that is a very big challenge for us.
Yes. Also worldwide, it's the same thing. That's why when they publish, we publish the document, we say that the important thing is you ensure that the supply of the radiopharmaceutical is there. Because it's important for your supplier to commit to the iodine. Because if it's not there, then you keep on rescheduling the patient, and it entails a lot of cost to prepare for the administration of radioactive iodine for the patient. Because as you said, or in most hospitals, the PPE is still very important, and you need to have the PPE available by your hospital, by the hospital. There should be adequate supply. And then the other important things would be appropriate distancing from the patient, both ways, again, radioactive and also infection control.
Yes, Tom. Patients who come into the nuclear medicine, as you said, would be best scheduled.
Yes.
Procedures like myocardial perfusion imaging takes a good number of hours in the. So do you tend to schedule cardiac procedures on Monday and Tuesday?
Yes.
Bone scans on Wednesday, Thursday. Is it how you do it in your center also?
Yes. In others, they would try to schedule them on a basis not conflicting with other patients, also for infection control. But the important thing is, I think for myocardial perfusion scanning, you still have to, as much as possible, try to do a one-day protocol. Okay. Yeah. And then so if it's try to shorten the protocol as much as possible, and then all 2-day protocols need to be reduced by 1. So something like that.
Okay.
If possible, yes.
Here's another question. Were there reports of COVID infection occurring within a few days or weeks post RAI? Did you have any?
Personally, no incident yet. Maybe I have to look more into the literature, but I think even with my colleagues here and then overseas, still I think no much report, because the nuclear medicine services I think were the ones really hit bad for, I would say, as far as operational processes are concerned. So most actually reduced to more than 80% of operations, because the hospitals tried to prioritize with the COVID patients. So by the time that the services slowly reopened, the infectious protocols are already in place, thereby minimizing possible COVID-19 infection to nuclear medicine patients. But also there are in literature that they do admit COVID-19 patients for either for PET imaging or for other possibly oncological diseases, and then they were able to see incidental findings of COVID-19 on the CT component.
Another question, Tom. What is the currently allowed dose for RAI ablation to be done on outpatient basis? Is this based on RP and RI guidelines?
Yes. again, based on PNRI guidelines pa rin, because it's all, you should base it on the policy of the country. So, but I did remember yesterday with, no, the other day with, in the PSNM convention that they do allow, at once I think they allowed it, uh, uh, iodine therapy outside the hospital. Yeah, but it needs to be on a case-to-case basis. Still, again, whatever is the law or existing policy, then it should be followed by it. There are actually no changes with that.
Okay. Another one, because of the presence of inflammation in the thyroid, will
Yes.
the effectiveness of RAI for treatment of toxic goiter post-COVID, yung patient,
Yes.
be affected? And then, is there a need for a dose adjustment?
I think there's no need for that.
Okay. And then, was there an incident that you have to close the department because your staff was infected with the virus?
Not with my department, because right now I'm actually working with the PNRI. Okay, but I think overseas, for example, in Singapore and also in UK, they have to close the department because of the staff were actually affected with COVID, so they have to close it. Again, priority is like, you try to minimize the infection, and also it depends on the policy of the hospital. So that's it.
Okay, I think that will summarize all of the questions that were placed on the chat box and the Q&A. Thank you, Dr. Pascual, again for your time and your lecture. And
Thank you.
we thank everyone who participated in today's activity. This will end our session for day 1. But we are inviting everyone to join us for our dinner symposium following shortly. So this has been Dr. Charles Tan, coming live from the Queen City of the South, Cebu. Thanking you all and wishing you all to attend on Wednesday's activity. Stay safe, everyone. Thank you.
Thank you, Charles. And thank you, Tom. I think that was a fitting finale to day 1 of our lectures of the PTA. I think pretty much we covered a lot of the important topics that in one day. No? So we covered the medical aspect of it, the surgical, and now the nuclear medicine aspect of it. Indeed, there's so many questions that were left unanswered. And I do hope that you join us again in day 2, this coming Wednesday, for another healthy round of lectures on the thyroid. And of course, the last day will be on Friday. So just to recap, some of the things that we learned today, indeed, the thyroid is one of the centerpiece as far as COVID infection may affect. No? So as we know, it's a metabolic organ. A lot of the things can actually occur if you have thyroid derangements, and this was clearly elucidated by Dr. Bien Matawaran. Dr. Sarmiento walked us through the changes of thyroid surgery and some of the contingencies that they've had to do in the face of the COVID pandemic. And of course, we had to strategize exactly how we will approach thyroid disease in the nuclear medicine aspect of it. I think it's very important that the lessons learned today will be applied to a lot of us in the front lines. And we're glad and we are very thankful for our lecturers today, as well as our wonderful moderators, for sharing their time and expertise to discuss matters of the thyroid kind. So once again, I want to thank all of you. I'm Dr. Jeremy Robles. I'm the scientific chair as well as the treasurer of the PTA. And in behalf of the board of PTA, we want to thank you for joining us for day 1. See you again on day 2 and day 3. That officially ends our first sessions for the PTA 2021 annual convention. Please stay for our next session. That will be the dinner symposium for Merck. Jen, are you ready to take over?
Yes, Dr. Robles, we will now go live.
Yes, Jen. So let's have a few minutes break, and then Merck will be taking over for their dinner simple. Thank you again, everyone.
Je, same link ba
Yes,
sa...
yes,
same link
yes.
ba sa ano?
Same link lang.
Hindi na lang
Yeah.
mag-leave.
It's the same link.
Okay, sige. Thank you.
Yeah. So while we are waiting for the dinner symposium, I just wanted to show to you the program for this coming Wednesday. That's February 10th. We again have 3 lectures. The first one will deal with hyperthyroidism. This is going to be lectured by Dr. Dimension Nicodemus, and he will be joined by his moderator, Dr. Alta Damalerio, who is from Cebu. Then we will have the lecture for hypothyroidism, and this will be done by Dr. Eric Mendoza, who will be joined by his moderator, Dr. Orabel Libutan from Bacolod. I will be doing the third lecture on the second day, and this will be on managing thyroid disease in pregnancy in the COVID-19 pandemic. It's a very interesting lecture, and we're going to look at some of the important data of how COVID actually affects pregnancy. And my moderator will be Dr. Raquel Bruno. She will be joining us from Iligan City, and that's in the southern Philippines in Mindanao. Of course, let's go through some of the lectures and as the schedule for Friday. Again, these are again 3 lectures. The 3 lectures that we have include the panel discussion on thyroid malignancy in the time of COVID-19. The speakers for this session will be Dr. Shoberg Ko and Dr. Wenceslao Lauderes. The session will be moderated by our endocrinologist from Bohol, Dr. Silvernon Israel. The second lecture will be robotic surgery in thyroid disease during the time of COVID. This lecture will be done by Dr. Jeffrey Geronimo Domino, who will be moderated by Dr. Domingo Sampang. And lastly, we have our last lecture, which is on telemedicine and teleconsult strategies for thyroid patients, which will be done by Dr. Nestor Eric Laplano and moderated by Dr. Arisa Soria. After that, we will close the session, and that will be our concluding activity this coming Friday for the 2021 PTA Annual Virtual Convention. So for today, I hope that you learned a lot. We're just waiting for Merck to actually get ready for our next activity as we close today's session with the dinner symposium from Merck. Okay.
audio.
Good afternoon. Welcome to the annual Philippine Thyroid Association Convention Dinner Symposium with the topic on goiter, more than a structural abnormality. This webinar is brought to you by the Philippine Thyroid Association with support from Merck Inc. Philippines. I am pleased to introduce to you our speaker. He is a clinical professor from the Department of Medicine, Philippine General Hospital, and Department of Biochemistry and Molecular Biology from the College of Medicine, University of the Philippines. He is also the current president of the Philippine Thyroid Association and past president of the Philippine Society of Endocrinology, Diabetes, and Metabolism. He is the current vice president of the Philippine Association for the Study of Overweight and Obesity. He's also a co-author of the Philippine Thyroid Disease Prevalence Study. Let us all welcome Dr. Nemesio Nicodemus Jr.
Good evening, everyone, and thank you very much for staying on with us for the first day of the virtual convention of the Philippine Thyroid Association. At this point, we would like to thank Merck for this dinner symposium, and it is also my distinct pleasure to share with you a very important topic, perhaps a topic that we all need to know about when we want to share these very important information to our patients. The title of my talk for tonight, Goiter, More Than a Structural Abnormality. The talk will be divided into the following parts. We will first deal with the hypothalamo-pituitary-thyroid axis physiology, then look at thyroid hormone synthesis, goiter formation and the classification of goiter, and end with management goals for non-toxic goiters. We all know that when we talk about the thyroid gland, it is really the hypothalamo-pituitary-thyroid axis that we must be familiar with. We know that the TRH, which comes from the hypothalamus, stimulates the anterior pituitary to secrete TSH. TSH, on the other hand, is the one responsible for making sure that the thyroid gland secretes T4 and T3. We know that 80% of the hormone released by the thyroid gland is in the form of T4 or your thyroxine, while 20% of it is in the form of T3 or triiodothyronine. However, peripherally, T4 has to be converted to the active hormone T3, and this is by means of the deiodinases. Subsequently, it is the T3 which promotes now growth and development, including cellular metabolism upgrade in various cells of the body. But this relationship between the hypothalamus, the pituitary, and the thyroid gland is not a one-way relationship. Very important is what we refer to as the negative feedback mechanism, where if your T4 and T3 concentrations are already above normal, these two hormones will affect the synthesis of the hypothalamus of the TRH and the synthesis of TSH from the pituitary, such that elevated levels of T4 and T3 will suppress releases of TRH from the hypothalamus and TSH from the pituitary. This now completes the cycle, which includes the negative feedback mechanism. Now let us concentrate on the synthesis of thyroid hormones. We know that the normal biosynthesis of thyroid hormones requires sufficient iodine. Iodine comes from the diet. Iodine which comes from the diet is absorbed and goes to the circulation in the form of iodide. Iodide, together with sodium, enters the thyroid follicular cells. And because of this, you now have the sodium iodide symporter, which is activated, allowing now iodide to enter the thyroid follicular cell. Inside the follicular cell, iodide is brought into the colloidal material by means of pendrin, and it is inside that the iodide is now oxidized into iodine. This particular process of oxidation from iodide to iodine requires the thyroid peroxidase enzyme. Subsequently, we know that because the thyroid gland produces thyroglobulin, that particular hormone which has a lot of tyrosine residues, your iodine now attaches to these tyrosine residues within the colloidal material. And this process, which we know as the conjugation, is really the iodination of tyrosine residues is very important and is also mediated by your thyroid peroxidase enzyme. This is now what we know as conjugation. However, after conjugation, another very important process which leads to the formation this time of your hormones T4 and T3 is also mediated by TPO, and that is now the coupling process. These hormones now, which are within the colloidal material, get to be endocytosed, and after a process of proteolysis are released from the thyroid follicular cell in the form of T4 and T3 as we know it, and then they go to the circulation. It is important that we are familiar with these processes that are involved in thyroid hormone synthesis, including the role of your thyroid peroxidase enzyme. Iodine, as we said, is very important. And to form normal quantities of thyroxine, 50 milligrams of ingested iodine in the form of iodide are required each year. Thus, approximately 1 milligram of iodine is needed on a weekly basis if we are to form normal quantities of thyroxine hormone. Iodides ingested orally are absorbed from the gastrointestinal tract and into the blood, and only 1/5 are selectively removed from the circulating blood by the cells of the thyroid gland. We also know that T4 has to be activated into T3 if it is to exert its metabolic effect in the different cells, and this entails the action of your deiodinases. There are 3 different types of deiodinases: D1, D2, and D3. And it is important that we recognize the importance of D1 and D2 because these are the deiodinases that activates your T4 into your T3. D1 and D2, the enzymes which activate our T4 to T3, are found in the liver, the kidney, the thyroid gland, the lungs, and the eyes. And the D2, which also converts T4 to T3, can be found in the brain, in the myocardium, the skeletal muscle, and even in the brown fat tissue. The other type of deiodinase, the D3, is the one that leads to the inactivation of your T4 to reverse T3. And D3 is also seen in the liver, the skin, the brain, and even in the placenta. The normal thyroid gland, as we know it, has a dimension that has already been measured in several populations. And the mean adult thyroid gland size are as follows. The length is between 4 to 4.8 centimeters. The width is 1 to 1.8 centimeters with a thickness of 0.8 to 1.6 centimeters and a sonographic volume between 7 to 10 ml. But there are specific facts that are interesting to note about thyroid volume. In general, the volume of the thyroid gland of men are larger than women. It also increases with age, and more obese individuals tend to have larger thyroid volumes. But the thyroid volume becomes smaller as you have a higher intake of iodine. These are important physiological facts that we must remember as far as the normal thyroid volume is concerned. Now, let's shift gears to the goiter. What is goiter? Of course, all of us are familiar that goiter is defined as a diffuse or localized enlargement of the thyroid gland at any stage of life. And goitrogenesis, which is the formation of goiter, really is associated with changes in the thyroid's ability to secrete adequate amount of hormones. And thus it is not just a physical increase in the thyroid gland size, but it is also a change in the ability to secrete adequate amount of hormones. And goitrogenesis is the result of the intrinsic glandular defects or even exogenous factors that modify the normal activity of the gland. Furthermore, goitrogenesis is an attempt of the thyroid gland to adapt to circumstances of impaired hormone secretion. Therefore, it is important for us to realize and to remember that goiter is the result of the adaptive response to abnormal hormone secretion. So, it's not just anatomy, but also physiology, which is abnormal when goiter happens. Goiters may be classified either as diffuse goiters, which may be toxic or non-toxic, or nodular goiters, which may be also toxic and non-toxic. Furthermore, the nodular goiters may either be single or multiple monodular goiters. When we talk about the prevalence of goiter in the Philippines, we have several figures that we can see. In 1987, it is estimated that 3.5% of Filipinos have goiter. In 1993, it was 6.7%. And in 2008, when the Philippine Thyroid Disorders Survey was done, or the PhilTides was done, the prevalence of goiter was 8.9%. Thus, approximately 9 out of 100 Filipino adults have goiter in our country as far as that survey is concerned. And when we talk about the PhilTides and the prevalence of goiter, remember that we have both diffuse and nodular goiters. Based on that survey, 56% of adult Filipinos have diffuse goiter. And this came from a sub-study of the 2008 National Nutrition and Health Survey, which covered 17 regions and 80 provinces of the Philippines. And in the same survey, around 44% of Filipinos with goiters have nodular goiters. Thus, it is important for us to realize how goiter develops, starting with the diffuse goiters. And when we do talk about non-toxic diffuse goiters, the first problem that we must recognize is that it is really an enlargement of the thyroid gland that initially occurs regardless of circulating TSH levels, and that the types are based on iodine sufficiency status of individuals. They may either be sporadic, non-toxic diffuse goiters, which affect those living in areas of iodine sufficiency, or the endemic, non-toxic diffuse goiters, which affect those living in areas of mild to moderate iodine deficiency. When we talk about iodine sufficiency, it is important for us to review that based on epidemiological criteria, sufficient iodine intake is at least 100 microgram per liter based on a median urinary iodine concentration of the population. And thus, a population will be considered to be iodine deficient if the median UIC is less than 100 microgram per liter based on population studies. The question is the Philippines iodine sufficient? We have looking at FNRI 15, we see that the median urinary iodine among Filipinos of different age groups is seen here. And if you look at the percent of the UIE values that is less than 50 microgram per liter, and therefore that is already mild iodine deficiency, clearly among Filipinos, adolescents, 20% already have the mild iodine deficiency, and you can see that among Filipino adults, 22.4% already have iodine deficiency, and this tends to be worse in the elderly and even among our lactating and pregnant women. Therefore, how do we solve and make sure that our population has adequate iodine intake per age group? It is important that we recognize the requirement of the individual based on the age, and see here that among adults greater than 12 years of age, the recommendation of the World Health Organization for adequate iodine intake is 150 micrograms per day. Pregnant women will need 250 micrograms per day, and lactating women will also need 250 micrograms per day for them to have sufficient iodine intake as defined by the World Health Organization. Knowing this, therefore, let us look at selected foods and the content of iodine that they have. See here, of course, that majority of us would advise our patients to eat seafoods whenever we think of increasing their iodine intake. And indeed, per serving of your seaweed or your dried nori, that is a 10-gram seaweed, will give you 232 micrograms of iodine. Cod, or the fish known locally as bacalao, when it is baked, a 3 ounces will give you 158 micrograms per serving, and Greek plain yogurt will give you 116 micrograms per serving. And thus, if in a typical adult, your requirement per day should be 150 micrograms, then eating perhaps cod and seaweed will give you more than adequate iodine for the day. And we see here that there are several other food groups with iodine content listed here, and I would just like to emphasize that our iodized table salt, approximately 1/4 teaspoon, contains 76 micrograms of iodine, while your normal sea salt, which is non-iodized, only has less than 1 microgram per serving. Thus, it is important that we distinguish between non-iodized sea salt and your iodized table salt. So, if you want to hit your 150 micrograms on a daily basis, you will have to be having these servings of food. Yung yogurt, 75 microgram per cup, so you might need 2 cups of that. Your pasta only has 27 microgram per cup, and therefore you will have to really take a lot in order to have 150 micrograms. Your seaweed, 40 microgram per sheet, so you will just have to get at least 4 of that. Your iodized salt, as we said, the 1/4 teaspoon contains around 71 micrograms, and your fish sticks, 3 ounces, will contain 54 micrograms. So you will just need, of course, 9 sticks of 9 ounces rather of your fish sticks in order to get your 150 microgram of iodine. Having said that, now it is important to realize that a persistent increase in TSH stimulation due to chronic iodine deficiency in non-toxic diffuse goiter leads to the homogeneous increase in thyroid size. Therefore, you have to make sure that the iodine content is maintained to the normal in order for us to correct this chronic iodine, which will stimulate TSH release. With this, there is a homogeneous increase in thyroid size but maintenance of the normal morphology of the thyroid follicles. The structural heterogeneity that develops later in nodular goiters, or rather in non-toxic diffuse goiters, may be due to the greater sensitivity of different follicles to TSH stimulation even when TSH is within normal levels. So within the thyroid gland itself, there is already heterogeneity in the sensitivity of the follicles to the TSH even when the TSH is normal. And this is illustrated in this graph here, wherein on the left panel, you have minimal TSH, and on the right panel, you have maximal TSH. And depending on the sensitivity of the thyroid follicular cells, the growth will be different. You can see here on the left, with minimal TSH stimulation, only a small fraction is really stimulated by and characterized by high intrinsic growth rate, while with increasing TSH concentration on the right, additional cells with higher threshold of responsiveness are gradually recruited for the proliferating pool. And thus, you have goiter formation. And when you talk about colloid goiter, there are several causes. Of course, there are certain physiological states such as puberty and pregnancy, which may lead to goiter formation. Increases in the TSH secretion, as we have already mentioned, which may be due to chronic iodine deficiency, such as seen in endemic goiter. But we can also have drug-induced goiter and even goitrogens. And I'm sure at one point during your practice, patients asked you about certain foods that might cause goiter. And this should be our answer to them when it comes to certain natural goitrogenic agents and their mechanisms of actions. See here that lima beans and sweet potato, including cassava, contain cyanogenic glycosides and are metabolized to thiocyanates that can compete with iodine in thyroid uptake. Cruciferous vegetables such as cabbage, cauliflower, broccoli, radish contain glucosinolates, and the metabolites compete with iodine in thyroid uptake, whereas soybeans, millet, and even coconut contain flavonoids that reduce the activity of thyroid peroxidase enzyme, and seaweed or kelp, if in excess, the iodine excess inhibits release of thyroidal hormones. It is important for us to realize that these mechanisms of goitrogen formation or goiter formation only happens with chronic excessive intake, of course, of these certain foodstuffs. There are also certain nutrients that are natural goitrogens. Selenium deficiency results in accumulated peroxides that can damage the thyroid, and even deiodinase deficiency, which alters hormone synthesis. Iron deficiency reduces the activity of the heme-dependent thyroid of iodine prophylaxis, while vitamin A deficiency increases thyroid size by increasing the pituitary TSH beta messenger RNA and TSH. Thus, it is important that we recognize selenium deficiency, iron deficiency, and even vitamin A deficiency as possible reasons for goiter formation in some of our patients. From diffuse goiter, let us now go to nodular goiters. And, of course, other than what we know morphologically, that your nodular goiters may either be solitary or multinodular, it is important that we recognize how nodules form. So solitary nodules display more uniform clinical, pathological, and molecular pictures, while your multinodular goiters are really mixed nodular entities wherein there's a combination of thyroid lesions that produce excessive, deficient, and normal amounts of hormones, and that the balance of the functional properties of the individual nodules with the function. So really, the nodules there are really heterogeneous in terms of their function. Hypothetically, how does the multinodular goiter develop? It starts with a goitrogenic stimulus, which is in most cases iodine deficiency, which is the earliest step. This is then followed by the heterogeneous hyperplasia of thyrocytes with diverse growth capacity and TSH sensitivity and response. Subsequently, there is a periodic increase in functional activity and number of thyroid cells, which leads to thyroid nodule development over time. And there is increased mutagenesis either by direct or indirect mechanisms, and eventually development of heterogeneous clones with somatic mutations. And so there it is. It starts with iodine deficiency, eventually heterogeneous hyperplasia of thyrocytes with differences in their TSH sensitivity and response, which leads to nodule formation, and that will lead to nodule development of different sizes over time. If in graphical form, this is how we can view the hypothetical physiopathology of multinodular goiter. Starting with increases in your TSH, which stimulates now the thyroid, and together with iodine deficiency and even genetic susceptibility, you have hypertrophy of your thyroid gland. With an efficient adaptation of iodine metabolism, you now have diffuse goiter. But if you have inadequate adaptation to iodine metabolism with alteration in hormone synthesis, you can have proliferation and mutagenesis that will lead to somatic mutations and development of goiter with cell clones, including that will now lead to nodule formation and eventually multinodular goiter. Therefore, if we are to look at how our thyroid becomes from normal to diffuse goiter to nodular goiter, it will look like this, that over a period of months to even years, you can have an initial enlargement of your thyroid with single cells with somatic mutation. Eventually, you will have goiter with cell clones containing somatic mutations, until finally expansion of cell clones with advantageous mutations that lead to multinodular goiters. How then do we manage diffuse or nodular non-toxic goiters? It is important that we follow these 5 principles. Number 1, we must correct the underlying thyroid dysfunction if present. We must verify if the goiter is growing or causing obstructive symptoms. We must exclude malignancy if one or more nodules are suspicious. We must determine whether the goiter requires therapy, and if so, you must weigh the benefit and the risk of medical and surgical interventions. And very important, we must reach a decision with the patient about what type of treatment should be administered. And it is important for us to remember that goiters are really a manifestation of both hypothyroidism and hyperthyroidism. And thus, when we talk about evaluation and imaging of patients with nodules, evaluate level, you have or values, you will now proceed with your imaging. For patients with subnormal TSH, we may request for radionuclide imaging procedures and ultrasound with cervical lymph node survey. And it is important that for all patients with thyroid nodules that we request ultrasound with a survey of the cervical lymph node areas. And when we do look at their functional status, we know that we can either have normal, subclinical, or overt thyroid hormone abnormalities. And if we look now in the Philippines, as far as thyroid disorders are concerned, we see that from the field tide studies actually have normal. It is important to note that there are patients who have clinical hyperthyroidism, subclinical hypothyroidism, and even overt hyper and hypothyroidism in the PhilTides 1 survey that will require treatment. Now let's look at the role of medical or surgical therapy for benign thyroid nodules. And here, I refer you to the guidelines of the American Thyroid Association in 2015. For benign thyroid nodules in an iodine-sufficient population, routine TSH suppression therapy is not recommended, and it may even have potential harm for modest response to therapy outweighs the benefits. For those with benign, solid, or mostly solid nodules, they should have adequate iodine intake, and if there is inadequate dietary intake, they must be advised to take daily iodine supplements. And for growing nodules that are benign on cytology, there is no data to recommend the use of thyroid hormone therapy. So in summary, my dear colleagues, what have we learned in this particular session? Number one, that goiters are enlargement of thyroid gland that develop as a result of impairment of hormone synthesis. Two, that goiters may also be manifestations of subclinical and overt thyroid disorders, both hypo and hyperthyroidism, and that management of goiters must address the underlying thyroid dysfunction and should weigh the risks and benefits of treatment, because in the end, when you talk about goiter, it's not just an anatomic abnormality, but very importantly, it has physiological thyroid abnormalities as well. Thank you very much.
Thank you, Dr. Nemi. It was a very informative lecture. And me, myself, although I learned about goiter way back in medicine, I just realized now that goiter thyroid enlargement is affected by several factors, such as sex, like males have larger thyroid, and also therefore men will also require more iodine than women. Now we open the floor for questions. We have already received several questions from our participants. So the first question is, what is the most common cause of goiter in iodine sufficient?
So in areas where there is iodine sufficiency, of course, we know that worldwide, the most prevalent cause of goiter would be your iodine deficiency. But in cases wherein you have iodine sufficient, such as, of course, the North American countries, the most common cause of goiters would still be the autoimmune conditions. You have Graves' disease, which may be the most common cause of goiter in the iodine sufficient countries, and therefore it's not just a goiter per se that you must deal with, but also the hyperthyroidism or the hyperfunctioning thyroid in such conditions.
Okay, from the chat box, there is a question. When would you recommend thyroid suppression?
Very good. In fact, when you look at the guidelines now by the American Thyroid Association, thyroid suppression is not in the recommendation. The reason for that is because even if there are studies, and there are, actually when I tried to look at randomized trials, looking at thyroid hormone suppression and goiter, there are actually studies, particularly studies that are done in Europe, wherein they would give thyroid hormones, levothyroxine at that, trying to give them high doses in order to suppress the TSH to subnormal levels, and they were able to produce significant reductions in the volume of the thyroid by as much as 50% reduction in the volume of the nodules. And so in such cases, even if there are studies, because these studies tend to be small, then the reason why it's not in the recommendation yet is because of course, you will have to have larger populations, larger studies in order for us to give a grade A recommendation for such treatment. And so the answer would be it depends on really the type of patient that you have. And that is where you must discuss the risk and the benefits of thyroid hormone suppression. You know very well that when you give exogenous thyroid hormones and you suppress the TSH, particularly for women, you of course increase the risk of osteoporosis. And for our elderly patients, or for those patients who have a pre-existing cardiac condition, of course, giving them exogenous hormones and suppressing their TSH will also increase the risk of developing subclinical hyperthyroidism, which might predispose to arrhythmias. And so you have to weigh all of these possible risks when you do give exogenous thyroid hormone in order to suppress the TSH. The risk and the benefits must be weighed, and this must be discussed with your patients so that they can choose the most appropriate therapy for these patients.
I think this is a follow-up question. How many months do we need to observe the patient if we started the patient on thyroid hormone suppression?
Good. It is important that, yes, it is important that when we do start our patient on thyroid hormone suppression therapy, that number one, we must ask them to come back at least after 2 months in order for us to check the TSH if it is really indeed suppressed to the level that we want it. And if we are to give the patient suppression therapy, then we must monitor these patients, particularly within 1 year, in order for us to assess whether there will be, number one, symptoms related to possible hyperthyroidism or subclinical hyperthyroidism. And then we must also do a repeat imaging procedure, because this will now be the objective measure for us to say that indeed our thyroid hormone suppression therapy is working. And if we are to look at the studies in the past wherein what they looked at thyroid hormone suppression for goiters, it is important that we do a repeat ultrasound. And I think that was also one of the questions in the chat box, that we do a repeat ultrasound at least after 6 months or every 6 months thereafter, in order for us to assess the effect of the treatment that we are giving to our patient, whether there is significant volume reduction, because in the absence of significant volume reduction within 6 months to a year, then perhaps it would be prudent for us to stop giving our patient thyroid hormone suppression therapy because of the other risks that are involved with thyroid hormone suppression therapy as well.
So another question in the chat box. What level of TSH is adequate suppression?
Okay. In the studies, if we are going to pattern my answer to the studies that have been done, adequate thyroid hormone suppression would require, there are two ways of suppressing the thyroid hormones. One would be just bringing down the TSH to the lower limit of normal for the reference range. That was done. And another one would be actually suppressing it to below normal levels. That would mean the TSH should be in the levels of 0.1 or even less. So in these studies, they were able to show that suppressing the TSH levels to the lower limit of normal versus those that would suppress it to less than 0.1 actually just gave you the same degree of reduction in the thyroid hormone and in the thyroid volume after the treatment. So really the take-home message there would be just to suppress it to the lower limit of normal and not go below that.
There's another question in the chat box. Is it possible that goiter can be hereditary?
Because we know that the genes, of course, in the parents would be transmitted to offsprings. Therefore, in patients who have goiters, there is a possibility that this can be transmitted to the offspring. However, a lot of it is also influenced by environment, and this is where iodine intake would come into the picture. And so even if it is hereditary, the formation of the goiter would still be dependent on the environmental factors where the person is exposed to. And that is basically, that is really the iodine intake.
So it's both hereditary and based on iodine intake, which
Yes, it's
also
both.
a pattern in a family.
Yes, it's both genes and environment.
Another question here, what is the best management for cystic nodules?
Okay. For the cystic nodules, we know that although when we do look at the guidelines seem to be quiet about the management of cystic nodules. But if indeed proven that these are benign cysts, what we know is that for some of the patients, particularly those with obstructive symptoms, aspirating these cysts would actually greatly alleviate the obstructive symptoms of these patients, and not just perhaps obstructive but even aesthetic. Some of the patients would really have very large goiters, and that after aspirating these big cysts, and if they are benign, they would really go flat. But the thing is, after a while, there will also be recurrence of the cyst formation in these patients. And so in other situations, there are some physicians would, after aspirating the cyst, give these patients thyroid hormone suppression therapy in the hope that there will not be a recurrence of the growth of the cyst. So but then again, there are no clear guidelines as far as the management of these cysts are concerned. And I know that there are also some of our colleagues who also do ethanol injection, in that after aspirating the cysts, you would actually inject ethanol in the hope that, of course, you will be able to close the cyst so that there will be no further formation of the cyst eventually after you have given these patients ethanol injection.
So there is a greater incidence of recurrence if the nodule is cystic, and then you do
Yes.
ethanol injection to eradicate the cyst.
That is
Okay.
one of the ways by which some of our colleagues, and there are also studies on that, although small studies, that indeed ethanol injection may be beneficial for some of these patients, particularly those with recurrent cysts.
Mm. Another question here, when would you refer a patient for thyroidectomy? Would it be based on volume of the thyroid mass, or duration of mass, or presence of symptoms?
You know, that is a very, very good question, because that's often the clinical dilemma, or the dilemma of the clinician whenever a patient is in the clinic asking whether I should undergo surgery or not. Of course, there is no one parameter that we can use, but you actually use all these parameters. It will definitely be based on the actual size of the thyroid gland, the duration, and the presence of the symptoms. The patient would definitely be the best person to ask if the patient has dysphagia, has a dyspnea, has obstructive symptoms. Definitely, these are signs that would require, that would tell us that surgical removal of part of the thyroid or the entire thyroid would be needed. Of course, the thyroidectomy part. And of course, aside from asking the patients for symptoms, the characteristics of the nodule on ultrasound would be very important as well. If the collective characteristics of the nodules on ultrasound points to a higher risk of malignancy, and the fine needle aspiration also reveals malignancy or highly suspicious for malignancy, then these patients must be advised thyroidectomy. Otherwise, if you have patients with nodules that are small, benign looking on sonogram, and on biopsy they are benign, likely benign, then you may give the patient the option to just observe these nodules, perhaps do regular ultrasound, and then if they are asymptomatic, you may just ask them to come back on a regular basis for monitoring purposes. And then once they do develop symptoms and obstructive symptoms, then that's the time you may refer them to the surgeon for thyroidectomy.
So it's more of the obstructive symptoms when patients start to feel those like dysphagia, difficulty of swallowing. So
Yes,
that's
and
the
and
time.
also the characteristics of the nodules and even the fine needle aspiration cytology would
Yes,
really be
ma'am.
very important in decision making.
Another question here. What will be your first recommendation to a patient with mass in the neck?
Oh, very good. So if the patient
Mhm.
comes to us in the clinic with a mass in the neck, of course, let us not automatically say that it is a goiter because we know that there can be several masses in the neck, and it's important that we do our history, our targeted history. Of course, even our physical examination will be able to tell us whether this mass is of thyroid origin or even extrathyroidal in origin. And it's important that if we are not sure as to the etiology or the organ involved in the mass is concerned, that we do imaging procedures. And the ultrasound would be, of course, the easiest procedure to perform if you are not sure and if you cannot really delineate what organ it is that is near your neck. Have a classic example would you if you can have this be easy distinguished from a goiter by just a simple maneuver of asking the patient to protrude their tongue, and of course movement of the tongue would also cause movement of the mass, and that would be highly likely be your thyroglossal duct cyst. And of course the physical exam will also aid us in distinguishing the different types of neck masses.
Another question here. What do you usually do or advise to patients who are hesitant to undergo surgery if clinically indicated?
Of course, the last phrase there is important, if clinically indicated, because we know that there are reasons why we would recommend surgery. And as we have already mentioned that a while ago, if there's a high degree of suspicion for malignancy, if there are already obstructive symptoms, and these are very, very important indications for surgery. Now, of course, the patient may have his or her own reason why they would be hesitant to undergo surgery. But for me, I think the best thing to do is to really ask the patient, are you really bothered by the symptoms, the obstructive symptoms? Because if you are, then surgery will really help you. And on the other hand, if there is a high likelihood that this is malignant, then discussing that malignancy, particularly for thyroid cancer, is something that can be easily managed after surgery with radioactive iodine therapy. And therefore, in such cases, by telling them that the prognosis will be very much improved by surgery, I think you can convince your patient to undergo surgery.
Another question here. Do you always remove thyroglossal duct cyst?
Okay, and I know that we have colleagues in our group who are otorhinolaryngologists, our ENT colleagues.
Yes.
Of course, these cysts we know are really developmental in, no? Of course, as because of the abnormalities in the development, there is the development of the thyroglossal duct cyst. And in cases wherein the patients are not really bothered by this cyst, it is not always necessary to have them removed. Of course, there are certain conditions that will require that will really let us recommend surgery, such as if there is pain, if aesthetically the patient wants to have them really removed because of for aesthetic reasons. Some there infections, therefore the
What is your parameters? Another question here. What is your parameter or criteria to do surgery for hyperthyroidism?
for hyperthyroidism. Okay, so we're talking this time of hyperthyroidism, and definitely I will also echo what the American Thyroid Association gives as far as the parameters to consider when recommending thyroidectomy, this would, of course, number one, be for those patients where they have adverse reactions to oral antithyroid drugs. Number two, for patients that have also obstructive symptoms. We know that for some patients with hyperthyroidism, the goiter may be really large, that they will also develop obstructive symptoms. And in some cases, even if hyperthyroid patients, there's a rare chance that they are malignant. There are cases wherein you have malignancy with hyperthyroidism, and in such cases, definitely thyroidectomy is needed in order for us to remove the thyroid gland and to give subsequent treatment for thyroid cancer. So, number one would be obstructive symptoms. Number two would be if there is really a high suspicion for malignancy. So these are patients that would wherein I would recommend surgery for treatment. And of course, adverse reaction to oral antithyroid drugs.
Another question here. As clinicians, do we need to do routine TSH testing in all patients presenting with goiter?
That is a very important question, and the answer to that is yes. We need to measure thyroid function among our patients with goiter, and the most sensitive parameter would be your TSH. A normal TSH, of course, rules out hyperthyroidism and hypothyroidism, and if it is normal, somehow you would be more confident that you don't need to do any additional management for these patients, other than, of course, ruling out malignancy. But if they are hyperthyroid, if the TSH is low, you have to check your T4 and T3 and manage hyperthyroidism accordingly. And if it is elevated, your TSH is elevated, then you have to ensure that the T4 or T3 is also measured in order for you to manage hypothyroidism appropriately.
Okay. I think this is the last question. Will thyroid hormone really cause shrinking or decreasing the size of the goiter?
Yeah, as I mentioned earlier, there are studies, and majority of these studies were actually done in the early 1900s and even early 2000s. We don't have any newer studies in the last decade. A majority of the studies using thyroid hormone suppression, of course, showed that there is a reduction in thyroid volume when you actually give high doses of your thyroid hormones, particularly levothyroxine, in order to suppress the TSH. But then majority of these studies are really small studies, and that's why they are not yet included as class 1 or grade A recommendation in the American Thyroid Association's guideline that was published in 2015.
There are still questions, 2 more questions. How do you propose to improve the very low threshold for surgery among our surgeons?
Of course.
The extent of unacceptable level of unnecessary surgery.
Well, as clinicians, of course, we would rely to the clinical judgment of our colleagues. And really, the question there with Dr. Ida Lim, is that is there really a lower threshold among the surgeons for doing surgery? Of course, it's a professional and a clinical judgment on the part of our colleagues, which is something that we cannot question. Of course, at that time, we don't know the parameters that are present in their assessment of the patients, but I trust that our colleagues, our surgeon colleagues, really would do what's best for the patients. And I think they would really look into the parameters that are important before they would recommend surgery for our patients. Similar to what we do. We as endocrinologists, when we do know that it is time for us to refer to our surgeon colleagues, then we refer. Of course, and I do think that among our surgeon colleagues as well, they would recommend what's best for the patients.
Okay, since we are running out of time, this will be the last question. So this is a follow-up. I think this is more of a comment. However, the risk of thyroid storm is high for hyperthyroid patient if they will undergo surgery.
Oh, that's very important. That you do not actually subject your patient to surgery if they are hyperthyroid still. If upon your assessment, this patient with hyperthyroidism would be a good candidate for thyroidectomy, you do not clear them for surgery not until you have rendered them euthyroid. In that way, you will actually reduce the chances of these patients of developing a storm intraoperatively. And that's very important. I think that's a very good question that we must clarify, that you do not recommend surgery to a patient with hyperthyroidism unless you have controlled their hyperthyroidism before recommending thyroidectomy. Otherwise, as was mentioned in the comment, you actually increase the risk of going into a thyroid storm on the table.
Okay, I think this is a good question, and although it should be the last, so maybe it's good also to answer this. What will be your advice to a patient with accidentally transecting the parathyroid gland during surgery? So the patient, the parathyroid gland of the patient was transected accidentally.
Okay, and although I am not a surgeon, I know that our surgeons really look into the parathyroid gland whenever they do thyroid surgeries. But of course, incidents like this may happen even at the best of hands. And in such cases, it's important that we, of course, monitor the serum calcium levels of our patients post-operatively in order for us to ascertain whether these patients would require calcium supplementation post-operatively in such cases wherein you have accidental surgery of the parathyroids during a thyroid surgery.
Okay, this will be the last. Last na talaga to. Is it advisable to check also the serum iodine levels of patients with goiter?
And no, we do not. And in fact, even when we want to assess the iodine sufficiency of a particular population, we do not do it on a single individual. It is really a population-based study of the urinary iodine excretion.
We have already covered all questions. And again, I would like to thank Dr. Nemesio Nicodemus Jr. for a very informative lecture on goiter. Remember, goiter is more than a structural abnormality. So I also would like to thank the participants. Maraming salamat po, and also PTA for this dinner symposium. Thank you very much, and have a good day and a good night to some, because some participants are from different countries also. Thank you very much. Maraming salamat po.